patients. By looking at this small building, we do wonders in that facility. We have about 26,000 registered sickle cell patients, and daily attendance varies to 50, at times above. It depends on the season. If it is raining season, then we can have about 100 patients a day. We have special clinics, that's hydroxyurea clinic, renal clinic, elderly, yes, we have elderly sickle cell disease patients. We have leg ulcer clinic and obstetrics. We don't attend to obstetrics patients there. We only diagnose and refer them to ONG. And this is Department of Child Health at the same Kolebu Teaching Hospital. Over there is almost 4,000 patients registered, both sickle cell SS and SC. We don't really monitor careers, that's AS or AC. Most of them are put on hydroxyurea because we are well educated about this drug, and we closely monitor side effects. So Accra is the capital of Ghana, and we are moving to urban areas or tribal areas. What do we see there? No roads, right? There is no road, there is no railways, no metro, nothing. So what do we do? We fly. So we have Zipline International company, which is based in America, and it has distribution centers in few countries, and Ghana is among them. What do? They deliver essential and critical care products, such as whole blood, platelets, frozen plasma, medicinal products, etc. We'll continue drones in Ghana, right? So there was a contract signed with government with them to deliver hydroxyurea to the distant part of the country. But the first delivery was yellow fever vaccine. That will happen in 2019. Now we have 6 distribution centers in Ghana, serving over 2,300 facilities, health facilities. And the aim is to achieve in the near future to 3,200 facilities, so that we'll reach every corner of Ghana. And the solution, as we said, there is no roads and a limited number of trained personnel. So telemedicine can be a solution for that problem. So you can have a live consultation with the specialist remotely. You don't have to travel or bring patients from the village to the city. We can monitor patients' symptoms, adjust treatment plans, provide timely interventions, and also adjust and train local health workers. We don't appreciate when it is one-man show. We always want younger doctors or volunteers to get feedback from the city. Then what it does, it reduces delays in assessing of proper medical care. Ultimately, it improves health outcomes in undeserved regions. Apps, we can use apps. We have Sickle Cell Foundation of Ghana. You can see the symbols, they call them Adinkra symbols. The one down means in the form of this one means vigilance, and this one is kin over all Adinkra symbols. It's from one of the old tribes in Ghana called Ashanti, and it is very significant that they used it for Sickle Cell Foundation Ghana. So this Ahojo program was bringing mobile devices and distributing them among the health workers. A pharmacist, for example, if it is at Kolebu, a steady pharmacist, then a doctor and a nurse. And a data manager will be entering hydroxyurea use. This one, it means unity. This one, I just put it, I just like it, for you to appreciate Adinkra symbols of Ghana. We are in tribal health, right? Okay, so if that app was used purposely to monitor hydroxyurea, but we can utilize already existing apps. I'm not advertising them, but it's kind of, I do. Okay, so this one of the apps saved someone's life. What happened? At 3 a.m., our data manager received this picture. The mother who is coming from the same tribe, you know, it's very important to establish rapport and speak the same language with your patient. So the mother sent this picture. She suspected that there is something wrong. It's urine. And he quickly contacted the team, and we enforced him to bring the child, the mother should bring the child to the hospital. You know, in Ghana, when you are not well, you go to the pharmacy first, you buy medicine, then it's not working, then you go to nearby clinic, then after nearby clinic to another, then maybe herbalist, then prayer camp. So by the time you reach Kolebu, you get it very complicated. So we acted fast. The child was brought to the hospital, and life was saved because she had critical HB. It was 3.9 gram per deciliter. We treated the child and she was discharged home. We tried putting her on hydroxyurea before, but it did not work for her. She always had very low ANCs and very low platelets. So to monitor her full blood count was very difficult. So we decided to not keep her on hydroxyurea and continue regular treatment. Okay, so when I was talking about different complications of sickle cell disease, we mentioned the heart, right? By the age of 2021, a lot of sickle cell patients develop left ventricular hypertrophy. It's due to the hard work of the heart to supply red blood cells and oxygen to various organs. So for us to rule out if the patient, for example, complains about chest and the doctors are busy, we can quickly run ECG, and the modern technology can even diagnose. Of course, we will send it to cardiologists later, but we can rule out that we should not focus on the heart condition. We can point maybe stomach or any other problem. And this is my favorite transcranial Doppler test. It's a non-invasive method of measuring blood flow velocities in the arteries of the brain. So it's very portable. You can see the size of it is like 2 computers. This is the probe, and you will see left and right sides of the brain. And it measures mean velocity of left and right brain. And it doesn't treat sickle cell disease, but it helps to diagnose before the disaster happens. Okay, that's how it is portable. You can put it in the bag and carry wherever you go. Fortunately, we have another TCD at Kolebu. It was donated to us. You can see myself and Albert, we are operating a TCD machine. It's more sophisticated, and you can connect it to the internet, and through the team viewer, the sonographers from other parts of the world can join you and watch what you are doing. Actually, we had the training remotely. when it was a clinical trial and we needed to do sonograms as fast as possible, and our doctors, trained doctors, sonographers were so busy. So we had to step in and learn on the job. So this is a short video. It's like a music. When you see, to me, when you see nice sonogram and this normal, it shows that the child is safe. You can also measure it with adults. Okay, these are your sonographers. Albert, he's a nurse, as I said, and I'm a pharmacist. But we had to step in. Actually, we realized that it's not a rocket science, so anyone can be trained. But to review, we can, of course, send it to the professional sonographers. Policy innovation. So we'll leave this part to our politicians because there is so much to do, teams, so that the financial burden will be reduced for treatment of hydroxyurea. We have to implement, okay, we've started, but we have to do it all over the country, newborn screening, right? Then we have to make essential medicines more affordable and available. Back to our picture. We have in Ghana health facility regulatory authorities. And under that, we have all these stakeholders. How can they miss out this clinic? You can see with your naked eye that this is just the boxes, wooden boxes with the wires and plastered. And they put poor child under this heat or warmth. I don't know what it does. That's so-called technology machines. I'm not exposing Ghana, but it can happen anywhere in the world. So we have to be alert, and I want to create awareness what might happen in India. Some people pretend that will treat you, will cure you. So the lady wasted her time, wasted money, and it got complicated. Actually, when she was finally referred to Kolebu, we diagnosed her with lipoblastoma. Lipoblastoma is a curable disease. And you just do surgery, excise it a little deeper, and the child will be fine. But this heat from so-called phototherapy might have caused the tumor to grow bigger. So all the authorities in India should also be alert and be monitoring your health facilities. Learn from us, learn from our mistakes. Community involvement. Involving community is a crucial part. We should not underestimate our patients that if they don't speak English, they are dumb. Look at this lady from the previous picture, the mother of that child. She subconsciously thought there was something wrong with the procedure. So she snapped those pictures and she showed them to someone she could trust. And it happened to be me. And also, when you establish good rapport with your patients, they can tell you everything and they can help the community as well. So in Ghana, we also have gon beats. It means people go around and shout in different languages. In Ghana, we have about 80 languages. So people go around and ring that gon bells and shout about sickle cell to create awareness. Also in Ghana, you can't go to rural areas without informing the chiefs. Even if you are the president of Ghana, you can't just go there. You have to see the chiefs first before going into their vicinity. Then they have community champions. They can be also the speakers for us. Then also, we always focus on science. We do too much science and we left humanity aside. We should combine. I remember the first presentation for this beautiful symposium. One doctor said it's a combination. We don't treat the disease and leave human being itself. there is a spirit, there is dignity, there is something. It's a whole universe. And also, we can train patients themselves. You won't be surprised that patients can treat themselves without our help. You just teach them. I want to show you a success story. I'm showing you leg ulcer in sickle cell disease. This is a 28-year-old lady. She treated her leg ulcer for 5 good years. Every week she was going twice for dressing, in and out, in and out. You can see the skin is very dry. The wound is sloughy. And she was devastated. It's a young lady. She can't put on any dress. She can't do anything, and it's painful. So what we did, we bought her dressings, and we trained her how to do the dressings by herself. And she did it. In Ghana, we say pepe. It means it means she did it to how she was taught. And see the result. This is after 2 months, and this is 3 months. And this is the same patient. You can see on another leg, unfortunately, she had 4 ulcers. So this is another leg, and she had it very deep. You know, sickle cell ulcers, plastic surgeons, they don't grab them because the bed of the soil is not fertile. So if you do skin grafting and place it there, it won't take. It will be rejected. And on the donor side, I'm showing on the thigh, so the donor side can be also a sore. And they are anemic. Those surgeries are bleeding. Okay, so this is the success after 5 months. She treated herself, I would say. We couldn't put her on hydroxyurea. We tried. She was taking it for about a month. We did her full blood count before and after, and ANS were low. Red blood cells became very low, critically low, and also we know sickle cell hydroxyurea has adverse event. That's leg ulcer, so it worsened it. So she was not on hydroxyurea. Key points: reach out to your patients. Let's be more proactive. We know time is money, but time is life.
Thank you, Dr. Kurang. It was a very comprehensive talk. I'm sure the audience have gained a lot from the wisdom and years of experience that you have. We now move on to the next session. To deliver the next talk, we have Professor Leon Shilolo. He's a renowned expert in pediatric hematology from the official University of Bujimai, Democratic Republic of Congo. He will present on newborn screening and early diagnosis of sickle cell disease in the Democratic Republic of Congo. Professor Shilolo, we look forward to your insights.
Thank you very much. I'm very grateful to the organizers for inviting me to this very exciting meeting, and I'm very honored to share our experience on newborn screening and early diagnosis of sickle cell disease in DRC. I'm learning many things. The next one, please. Okay. Thank you. As there are some students here, I would like to present first a short introduction with a kind reminder on the complex physiopathology of sickle cell disease. I will share with you some maps on the world distribution of sickle cell disease, and I'll talk you about the newborn screening, and after we will conclude with some points that we plan to do in the future. We know that globally, sickle cell disease is due to a point mutation, but there are 4 main haplotypes of sickle cell disease, and my country is in the central part of Africa, where we have the Bantu haplotypes. And these haplotypes is one of the more severe form of sickle cell disease. Just to remind that even though it's a genetic disease, as we have learned from the previous speaker, sickle cell disease is a systemic disease. It's also an inflammatory disease, rheology and microvascular and macrovascular disease, and it is also characterized by immune compromised and with the high risk of very severe infections. I would like just to show with this slide the relationship between the malaria due to falciparum parasite and the sickle cell mutation. And recently, with the Lancet Hematology Commission, we worked on the global distribution of sickle cell disease in the world. And as you can see here, most of the places where malaria is endemic have a high prevalence of sickle cell disease. And in this slide, we show that sickle cell disease is a cause of high mortality in under 5 children over the world. So when we think that since 20,000 to 2021, we observe an increase of prevalence of sickle cell disease with estimated around 8 million of people with sickle cell disease in 2021. And we have a high number of births of infants with sickle cell disease that will increase from 3,000 to 500 in 2021. When we compare the situation of sickle cell patients between high level countries and the low income countries, for example, comparing with the USA, we can see that in USA they have around 2,000 new cases annually. And in USA, diagnosis is made during the newborn period. They can access to penicillin, vaccines, hydroxyurea. And 19.5 of children can survive to adulthood. And the number of new cases is around stable. When we move to the low-income countries, globally we have 400,000 new cases annually. And in most of the sub-Saharan African countries, there's no national newborn screening. And the essential drugs, because hydroxyurea is now recognized by WHO as an essential drug, but there's just a minimal availability of the essential drugs. And we have the highest mortality of these children by the age of 5 years. And in the next years, we will observe an increase of more than 30% of new cases by 2050.
According to the WHO data,
when you look at the when we look at the WHO map, we can observe that in the central part of Africa, the main prevalent abnormal hemoglobin is just S. So in Congo, in Gabon, and so on, and the prevalence of carriers is around 25%. Now I would like to spend some words about the Democratic Republic of Congo. It's the third most affected country after India and Nigeria. Presently, we can say that we have 120 million of people who are living in DRC, and we have globally 4 main ethno-linguistic groups. We have in the east part the Swahili group. In the middle of DRC, we have the Chiluba group. In the west part, the Congo group. And in the north, the Lingala group. And we have more than 200 tribes. And in most of these tribes, we have an endogamic marriage system. Congo is in the middle of Africa, where malaria is endemic. We have a high prevalence of HIV infection, Ebola, and now monkeypox. People is in majority poor. We have a high prevalence of undernutrition. And in the rural areas where you live majority of people and majority of tribes, we have only few health centers where it's very rare to find a doctor. The healthcare are in the healthcare centers, they are mainly nurses and not doctors. Globally, the population of DRC is Bantu people, so we have mainly the Bantu haplotypes. Sickle cell disease is a burden in DRC for the family because sometimes these children who are affected of sickle cell disease, they will be pushed out of the family because they think that it's witchcraft, and sometimes they think that sickle cell disease is a mystic disease to malediction, and these children will be in the street, the so-called street, children's street, and sometimes it's also a burden for the children because they can go through depression. So our experience of 15 years concern systematic newborn screening and early diagnosis in young children aged less than 5 years. We have done it mainly in Kinshasa, the capital of DRC, where we have all the different tribes are represented in Kinshasa. But we included also 9 other provinces. So globally, we have screened more than 100,000 newborns and 33 children aged less than 1 year and 22 children aged more than 1 year but less than 5 years. For that, we use dry paper. Because it's expensive, we cut just 1 centimeter of dry paper, and we took some essential data from the mother. The name of mortality, the ethnies, the tribe, and date of collection of blood. Send it to the our lab. in the Center of Excellence of Sickle Cell Disease. And globally, we use the IEF system for detecting the abnormal hemoglobins. And we make the confirmation of these cases using the capillaris electrophoresis. Here how are our first result. We have a prevalence of carriers in newborn of 16.8%, and globally we have around 2% of homozygous patients. It's just like the same result that the previous speaker presented from Ghana. But the newborn screening is not funded by the state. It's due to the NGOs and foundations. And this is the reason why the number of the newborn screened varied according to the funds. As you can see, in the first 10 years, we have done sometimes almost, we stop to do the screening because of absence of funds, and after we take it again. Now things are going a little bit better because you obtain some financial subvention. Globally, we screen mainly children aged less than 1 year. And when we look for the result, globally, the HBS allele, according to the ethno-linguistic groups, we can observe that people who are living in the center of Congo, in the Kasai province, have a high prevalence comparing to those who are living in the east part of Congo. In the east part of Congo, we have mountains, and it's near Tanzania and Rwanda, Uganda, and so on. And we have less malaria in the east part than in the center, in the west part, and in the north part of our country. So globally, in these children, the prevalence of carriers is around 15%, and the prevalence of homozygous patients is 2%. We don't observe cases of beta thalassemia. So we also try to understand the impact of the presence of the HBS allele, and we observed that there was a reducing number of children bearing the HBR allele when we observed the increasing with time in the children bearing the HBS. And this is a practical demonstration of the impact of malaria selection. So how can we explain this increasing prevalence of carriers of HBS allele? It's, as I said, due to malaria selective pressure, because the AA patients are prone to die because of a severe form of malaria, while the patients, the heterozygote patients, they have a relative resistance and they don't display severe malaria. So, and the increasing number of patients bearing the HBS allele is also due to the positive impact of introduction of newborn screening and early diagnosis of patients. And because most of the new patients that have been diagnosed are submitted to hydroxyurea. And probably there's a bias selection in this study, I agree. And the high number of patients bearing the beta-S gene is also due to the fact that we have endogamic marital system in most of the Congolese tribes. So now comparing the time before the introduction of the newborn screening our populations have a mean age of 9 to 10. With the introduction of newborn screening, we observe that we have two groups of children, because we have now young children aged less than 5 years and elder children who are now teenagers because of the introduction of hydroxyurea. So for the future, we plan to start with the newborn screening in rural areas. As we have seen from the previous experience in Ghana, it's very difficult. We hope that with the use of point-of-care devices, it will be easier to introduce the newborn screening even in remote areas. And we have also the chance to have a mobile lab that is specifically dedicated to sickle cell screening and follow-up. We plan for the next years to screen pregnant women in order to reduce the number of neonates that will be screened, because we will only screen newborns from pregnant carriers. And the introduction of early diagnosis as prone by WHO will be done during the vaccine schedule programs and before any blood transfusion, even in the case of emergency in the pediatric children. In that way, we can identify new patients who are sickle cell patients, but unfortunately, we are not being diagnosed as sickle cell patients. I'm very glad to thank you for your attentions, and I hope that we will make a bridge between India and Africa. Thank you.
Thank you, Professor Shilolu. We are indeed deeply grateful to you to having got this opportunity to learn from your years of experience. We now move to the final talk of this session. To deliver this talk, I would like to invite to the stage Dr. Anuj Singhal. Dr. Anuj Singhal is a medical director of Swami Vivekananda Health Mission, Uttarakhand, India. He would be discussing on sickle cell anemia, main factors affecting tribal health. Dr. Singhal, please take the stage, please.
Thank you very much. I have come from the Devbhoomi Uttarakhand. तो सभी को I would wish जय श्री केदारनाथ, बाबा की सब पे कृपा रहे. तो I wish, and first of all I would like to thank Dr. Sanjeev Chaudhary and Madam Kanitkar to invite me here for this prestigious first conference on tribal health. I would like to finish my talk fast, as few persons would be having hypoglycemic. Lunch is closing by. So first I would like to show you the work we are doing in Uttarakhand. Few slides. Then Dr. Korang and Dr. Leon has reduced my work by telling so many things about sickle cell. So then I will move that slide a little bit faster. So Swami Vivekananda Health Mission Society, we are established in 2012 to reach the unreachable areas and affording the unaffordable persons, especially poor, assessing the inaccessible, and serving the neglected, deprived, and underprivileged people. So it was founded in year 2012 by a group of young doctors and some philanthropists. Actually, I am passed out from SN Medical College, Agra in 96, and then I was in Wayanad, Swami Vivekananda Medical Mission for 15 years. And I was opportunity to work with sickle cell patients. That's why I'm here and talking about the sickle cell disease, because don't have much patients. And we started with a small dispensary, a rented room. Now we are having 14 charitable hospitals we are running, including Sri Kedarnath Dham, Sri Badrinath Dham, and Gangotri at the 12,000 feet height. So maybe this would be the only hospital run by NGO in this at this height. And we are now establishing hospital outside the Uttarakhand also, one small hospital in Delhi, and we are coming up with a 400 bedded hospital in Vrindavan. So this is our mission, to worship our motherland by serving the neglected, exploited brethren and pilgrims in the backward, rural, hilly and tribal areas, rendering them with medical education and other social aids. Our vision is complete development of the tribes, poor, socially deprived and other backward peoples. So coverage and impact: within 12 years, more than 20 lakh patients we have treated, and out of that more than 1.5 lakh emergencies, lab test 9 lakh. These are just the datas. And what we do, our thematic areas are charitable hospital, 14 charitable hospital, community medical camps, community health programs, anemia program, prevention and control program, breast and cervical screening program, community mental health program, MyPad program. We have a sanitary pad making machine where we production is there of high quality sanitary pads, and the girls from the tribal area are trained and they go to the villages and they teach them about the menstrual hygiene and give them the sanitary pads on monthly basis. More than 3,000 girls and ladies we are providing sanitary pads, and oral cancer screening program also. Apart from that, some self-reliance initiative for you would be knowing Mana is the first village of the Bharat, and we have trained them in woolen, different type of woolen clothes and some educational activities. These are our footprints you can see all over the Uttarakhand. First started from Dharmawala. It is a small village bordering Uttarakhand, Himachal Pradesh and UP. So 40 kilometers, and main population is Boxa and Jaunsari. 1 lakh tribal population is there. So we serve them. And then on all the Chardham Marg, Badkot on Yamunotri Marg, and then Uttarkashi on Gangotri Marg, and then Narayan Koti on Kedarnath Marg, and People Koti on Badrinath Marg. Then we came to know, as you know, pilgrims from all over the world and India came to visit these shrines for 6 months. These shrines are situated at the altitude of almost 12,000 feet. And due to that, lot of morbidity and mortality were there. So we plan to establish Chardham hospitals there. They are totally free and round the clock. Critical care are, we provide total, we have ventilators, ICU, and even we thrombolize the patient there itself. MI patients come there, we give the streptokinase injection, we stabilize them, and then we airlift them to AIMS Rishikesh usually. We have a tie-up with them. And a success story, one 30-year-old young boy, 30 years from Bangalore, he came over there. No comorbidity. He suddenly had severe chest pain, and we did the ECG and it was diagnosed MI. Immediately we thrombolized them and we shifted him to AIMS Rishikesh. Because of that, he could be saved. So lot of lives through that we saved because of teamwork. And this is our small Chardham hospitals. And we have all the facilities of ICU, ventilators, infusion pumps, warmers, oxygen, everything we have there. And even the other, because from the south, a lot of pilgrims come, they do not know the temperature and climate there, and rains always in hills. Any day it can rain. So we provide them the raincoats, slippers, blankets, and tea and biscuits we provide them. And by what we gained, So by establishing this hospital, we could brought down the morbidity and mortality rates by 90%. This is the official data, and these are our stat from the Chardham hospitals. You can see year by year it is increasing. So last year 2024, we could cater to around 1.85 lakh patients, and out of that almost 15% were severe emergencies, almost 25,000. And the common type of emergencies we deal with: respiratory, mainly cardiac, trauma, abdominal, neuro. So we daily do almost 7 to 10 plasters there, because lot of fall from there, from the mules, and the small roads are there. So from the God grace, we could help these pilgrims, and we are coming up with a 50 bedded high quality hospital at Kedarnath, near the temple only. So this is our data from the since inception. So you can see from 2012, 1,488 patients to nearly 5 lakh patients we are treating per year. So now come to sickle cell disease. So already I have told this Dr. Leon and my previous speakers, they have told about the sickle cell quite lot. So mainly affecting in Africa, Southern America, Arabian Peninsula, and Mediterranean countries. And 25 to 30% of neonates in Western Africa are carriers of sickle cell trait, and most of the babies are asymptomatic till the age of 4 months, 4 to 6 months. So I'm not covering what is sickle cell disease. Already they have told how this sickle red blood cells block the blood supply, because it gets stuck into the capillaries and causes pains and other symptoms. Mechanism already they have told. So anemia, basically because of this sickle hemoglobin, RBC's lifespans reduced to only 20 days. The normal life span is around 120 days. So chronic state of anemia, the patient comes, and regular blood transfusion they require. And because of that, now I was speaking to Dr. Chobe here, who is in blood transfusion medicine here. He was telling lot of antibodies because of regular transfusion, small these things, antibodies develop in the sickle cell patient against the blood transfusion. So lot of reaction happens, and it is one of the major challenge to provide them regular blood transfusion also. So these are the various symptoms: painful crisis, painful swelling of hand and feet, frequent infection due to low immunity, delayed growth in children, stunted growth. So anemia symptoms, they have this forehead bone would be stunting, you can see, and these cheek bones will prominent bones, and vision problems. And these are the few complications: stroke. Just the Doppler, regular Doppler is the preventive thing, so we can pick up which sickle cell patients are prone to get stroke. Acute chest syndrome, it is a major cause of mortality. Number one cause, you can say. The patient, sickle cell patient, usually the first number of mortality is acute chest syndrome, then pulmonary hypertension, organ damage, leg ulcers, blindness, gallstones, avascular necrosis. So most of the long bones, especially femur bone, they get avascular necrosis, and their life quality of life will be very poor. Some treatment part, preventive measure is the most important. Proper hydration. Once they have poor dehydration, so they can get VOC, vaso-occlusive crisis, and painful crisis. Adequate diet rich in protein. Avoid hard work, and vaccination to avoid infections. So medicines are folic acid, zinc, hydroxyurea. So now worldwide, each patient should get hydroxyurea. This is the rule. And we did one study when I was in Wayanad with Calicut University medical laboratory student. We screened around 300 sickle cell patient, and it was found zinc level less than 50%. So zinc is a very major this thing we should provide. Even in now diarrhea patient also, it is very much recommended. And newer drugs under research, this is TMCA to reduce, and Calicut Medical College is doing research. This is in injectable form. Once in a month they are giving, and it is very promising results. So vaso-painful crises have come down. And one Riva pencil also, it reduces vaso-occlusive crisis by preventing red blood cell from sticking to monocytes and neutrophils and improves blood flow. They are under research phase only, and some new therapies are like bone marrow transplantation, still debatable gene therapy. Prenatal diagnosis would be what I think should be have this labs all over where sickle cell patient is high, because in this only marriage counseling is important, but in marriage counseling full community is involved, the husband, wife, their mother, father, whole community, and it sometimes become stigma, what is my experience. Then if uh, boy is normal A, then sometimes family, if they are over aware, they say ki we, even they won't want to marry a carrier girl also. They say ki why we should bring this gene into our family. So it becomes sometimes social stigma. So but chorionic villus sampling, if we establish good centers, because it is a highly skilled procedures, and after that we have to do PCR, it can be a good solution to this sickle cell anemia. This is the genetic transmission, as you know. So if normal married to a trait, 50% can be carrier, 50% would be the normal, and normal with the SS all would be carriers, and trait with trait 25% maybe normal, 25% homozygotes, and 50% carriers. And this trait and anemia, 50% would be carriers and 50% would be homozygotes. So world scenario, already 90% of the world sickle cell disease population lives in Nigeria, Congo, and India. So India ranks third globally in the number of term SCD birth, 15,000 to 25,000 per year. And sickle cell patient is increasing year by year. In 2021, it was 7.74 million in comparison to 5.6 million in 2000. So scenario in India, one of the 10 major health issues affecting the tribals, and its prevalence varies from 1 to 40% heterozygotes. Few non-tribal communities are also affected. Just I was in Wayanad, one Wayanad and Chetty, they had the highest prevalence of sickle cell gene among them. They are one OBC group, and we could find few cases in Muslim, Christians, and Hindus also there. And we had a case of sickle HBSD also there. So India is the largest tribal population density globally, and 83% live in 10 states, mostly MP, Maharashtra, Odisha, Gujarat, Rajasthan, Jharkhand, Chhattisgarh, Andhra, West Bengal, and Karnataka. So out of 461 tribes, almost more than 125 tribes have this sickle cell gene. Approximately 1.2 million are affected from sickle cell disease in India, and Madhya Pradesh has the highest load with an estimated number of near 1 million, and heterozygotes, and around 70,000 homozygotes. And co-inheritance of sickle cell gene with beta thalassemia, HBD Punjab, and G6PD deficiency has also been reported. This is the madam had already shown in her presentation scenario in India. Maximum, if you can see, is it in central India. And we did one project. It was the first pilot project in India with AIMS New Delhi from when I was in Kerala. And duration was 98 to 2002. And principal investigator was Dr. I.C. Verma and Dr. Madhulika Kabra from AIMS New Delhi, from their genetic department. Both were pediatrician. And I had the opportunity to work as senior research fellow that 4 years. And objectives were to screen the whole tribal population of the district and to distribute them color coded cards, white for the normal, blue for the carrier, and red for the homozygote. So it would be easy, because most of the tribals were illiterate that time. So simply telling them ki white normal, blue carrier and red danger sign. And we used to marriage counseling ki when you are marrying one, either bride or groom, one should have white card. So other can be AS or SS, then their child will be normal. Then it was very much easy to explain them and to remember them. Ki one should have white card holder, so your children will be won't have this sickle cell disease. And to vaccinate the affected children below 2 years with the pneumococcal vaccine, Hib vaccine, and hepatitis B, 3 vaccine uh, we had given 2 years because of fund paucity. Only we could vaccinate below 2 years. After that, we AIMS Delhi recommended their recommendation to the state department to implement it. And to establish prenatal diagnosis also, we did 4 prenatal diagnoses in 98 to 2002, CVS. And we purchased, Dr. Suresh was there from the Mediscan Center, Chennai. He was the co-investigator. And we have the biopsy guided Aloka ultrasound machine from there. We did in Wayanad itself. And then we sent the sample to Hyderabad CCMB lab from where they diagnosed the cases. And some results, total tribal population of district Wayanad according to 91 census, what we took at that time, 1.21 lakhs. Main tribes are Panyas, Mullan Kurmas, Kurchas, Adia, Katnaikans. This is primitive tribal group, Katnaikans. And one non-tribal group also, Wayanadan Chetty. They had the maximum prevalence of sickle cell disease. We could screen around 1.07 lakh population. Screening method, we use sickling test for the screening, and those positive were underwent electrophoresis. On the blotting paper, we took the sample, and more than 1200 homozygote we could found, and carriers were more than 8000. And what intervention we did, because research is always there, as UHS is also doing. First we have to screen, then we have to find solution, and then we have to implement that solution. And we did the same thing. We did the counseling for the preventive measure. We trained all the ASHA workers and Anganwadi workers, all government doctors, and this thing. I used to take the class of there, what they have to, how they have to treat the patient, how they have to do the counseling. Marriage counseling, obviously, vaccination and medicines. We were giving hydroxyurea in since 98. And that time hydroxyurea was very costly. Then I approached the direct Cipla company. They were making it, that time it was 30 rupees per capsule, only 500 mg. And they were nice enough to brought that rate down to 5 rupees. They were supplying at the rate of 5 rupees, and more than 500 patients were under hydroxyurea. Though our criteria to start hydroxyurea was ki more than three painful crises per year, because we had limited number of stock. So we had very promising result. And we started rehabilitation center also, because they cannot do hard work. So with Bombay IIT, we send our trainers to there. They trained our trainer in bamboo handicraft. So all the sickle cell patients, they used to we had 3 rehabilitation center, and they make the bamboo products, and we market them. And we did one research in Ayurvedic treatment also with Kotakal Ayurveda, Kerala. And they provided one in this ghee, one case and control we could, and we got the good results. So just World Sickle Cell. And regarding National Sickle Cell Anemia Elimination Mission, so our Honorable Prime Minister Modi ji launched on 1st July 2023, which aiming to eliminate SCD by 2047. So just objectives are, to screen all the population and to integrate all the departments to reduce this thing, health promotion, prevention, and holistic management. So till June 1824, they have screened 3.37 crores. And out of that, around 1.4 lakh SCD patient was found. So way forward is, in conclusion, the comprehensive effort outlined through World Sickle Cell Awareness Day and National Sickle Cell Disease Anemia Elimination Mission highlight a dedicated commitment to addressing the challenges. So we hope by we work together, definitely we will eliminate the sickle cell disease. Thank you.
Thank you, Dr. Anuj, for the excellent presentation. Your talk did reflect the years of dedication, hard work, and perseverance to improve care. With this talk, we come to the end of this session on sickle cell disease. To sum up and also to share the valuable insights, I request our esteemed chairpersons on stage, Dr. Deepti Jain ma'am and Dr. Jala Valinda ma'am. Over to you, the chairpersons.
Good morning to all. If it's still in the morning, I can see that you all have been super saturated with knowledge of sickle cell disease. As I look across the audience, I see the lights on, and I know that we all are happy with what we learned about sickle cell disease. We know that it's in Central Africa, it's in West Africa, and Sri Lanka, and India. These are the places that we learned about sickle cell disease. We know that it affects all organs, it's very common, and we know that there is an elimination process on the way, and I'm sure we all are excited about that particular information. Now, speaking about the first speaker, Dr. Goran, I was very pleased with her presentation, and all three of the presentations were very uplifting. I know Dr. Frimpong personally, and I'm glad that the work is continuing in Ghana. We're impressed with the use of technology, use of drones to drop off blood and other drugs to the hard to reach area, which is very important because if you can't get drugs and medical supply to those who are far away, then all of your research is in vain. We're happy with the improvement in the and longevity of life, but we also know that it's sad that in the advanced countries, there are more tests available and more people survive longer there, whereas in the low income or low resource setting, children are dying a little bit early. But all of these research put together can help us to make sickle cell treatment, management, and the lives of those who are suffering from sickle cell a little bit more comfortable, affordable, and accessible. So, and we also know that we need policy and collaboration and monitoring, as we learned from our first speaker, in order to save their lives and improve the living conditions of those who are suffering with sickle cell disease. I will stop there and let my co-chair say a few words.
Thank you. I think we had a wonderful session. The three speakers had different domains which they were speaking. And in India, I think this is the first tribal conference, international conference. The first case of sickle cell disease was observed in 1952 by Cutman and Lehman in a tribal girl. It was first sickle cells were seen in a tribal girl. Since then, we have recognized sickle cell disease as a disease of tribal population. However, it is also seen equally in non-tribal. But the advances in management, in prevention, are not accessible to the tribal population as much as they are for the non-tribal population. Also, Indian government has given, I would say, lot of stress on sickle cell disease in tribal population, apart from nutrition and other conditions. It was in 1996, Jai Vigyan project by ICMR was done in 8 primitive tribals of India. We learned a lot. I think that was a landmark study, and many of the things which we are practicing today, as Dr. Das said about the color-coded cards, were from those primitive tribal studies. Also, we learned what we were taught, that iron deficiency does not occur in sickle cell anemia, but we did find during that study that there is lot of nutritional anemia associated with sickle cell disease. I would say sickle cell disease is evolving. Those were the days when we were using color card, coded card, and it worked very well. Let me tell you, it was much better accepted by the tribal population. We were surprised. They listened to us. That, as the last speaker said, that one of the groom or the should be white card holder, and they looked at it and then got married, which was very difficult in our cities to tell them don't marry, AS should not marry a AS, which is still difficult. So it is evolving, because today when we are looking at the national mission, when we started with the color coded card, there was lot of stigma, and we are not using this color coded card in the national mission. The most important thing which we have to take care is the stigma with sickle cell disease, and awareness and counseling plays a very important role, I would say, in this mission also. The other thing is, the title elimination of sickle cell disease. You cannot eliminate sickle cell disease. By elimination, we mean control of birth of a SS child. That is the meaning of elimination. You can't eliminate sickle by 2047. For that, the most important thing, as Dr. Leon said, he's a good friend of mine, about newborn screening and how he described the different haplotypes which are there with sickle cell patients across the world globally. We are Arab Indian. We are very different from what is there in Africa, the Benin and the Cameroon. We have to remember that we should have our protocols for Arab Indian haplotype, which is different. Other thing is to control birth of a sickle cell. He very well described the newborn screening, and I agree with him. He added early diagnosis. We just talk of newborn screening. It is not feasible always. You must have diagnose as early as possible. He kept it as less than 5 years. In the mission, we have kept it as 3 months, because that is the time when the patient, the baby comes in contact for the immunization. So you can do sickling even during that time. We have point of care tests, 18 point of care tests made in India, which are validated by ICMR. They are cheap, 100 rupees, while the other available tests were very expensive. Even the hydroxyurea is locally made, and it is available now. It was previously available only in 500 milligram capsules, but now we have very cheap tablets. The syrup is difficult because the stability of hydroxyurea, and we use 200 milligram tablet in children, which are available. I think we were not, many of not aware of this availability of 200 milligram tablet. But the message one I will like to give here is, all what should be made compulsory is all antenatal mothers in first trimester must undergo test for sickling and thalassemia to prevent child born with a thalassemia major and sickle homozygous. I think that is the message we must, all of us do, each one of us, that all antenatal mothers must be screened for these two hemoglobinopathies. It's a must. I'll go on, but I know people are having hypoglycemic attack, and I would stop here, but we'll be happy to discuss any other thing. Thank you. All the speakers were very good. The technology used in the tribal area of Ghana, I've witnessed the marriage in Ghana, and we must give credit to Waku. With the first speaker started her talk with him. He is the one who I think has led sickle cell disease in Africa. And we have seen these bells ringing in marriages where they are talking about awareness in sickle cell disease. Congo, yes, we have seen Congo. One thing I would like to tell about Congo is their empress, the princess of Congo, she is so much involved in taking action against sickle cell disease. So I think these are few things which are there, and as we know that the Wayanad district in Kerala, the other evolving thing is we used to think there are five states which have high prevalence of sickle cell disease in India, a belt. No, now we are coming to know Rajasthan is has as much as we have in Maharashtra, Jharkhand, and other states. We know that sickle cell disease exists in large numbers. So I just want to say what I say today may change in future about sickle cell disease. But we are doing a lot for tribals in sickle cell disease. Thank you.
Thank you, ma'am, for your valuable insights, and that brought a meaningful end to the session. Now, I'd like to request our chairpersons to felicitate the speakers of this session and request the esteemed speakers to be on the stage for felicitation. Dr. Karang from Ghana. Thank you, ma'am. Professor Leon Chilolo from Congo. Thank you, sir. Dr. Anuj Shingar from India. Thank you, sir. I now like to invite Dr. Lilia Tariosian from Armenia and Dr. Sandeep Soni from US to felicitate our chairpersons, Dr. Deepi Jain and Dr. Jala Wilhelmina. Thank you, ma'am. Thank you, sir. That brings us to the end of the second scientific session of today. I request everyone to kindly join us for the lunch at retreat. We will meet again post lunch here sharp at 2 p.m. for today's third scientific session with the exciting theme of climate change and tribal health, a global viewpoint. Please take a moment to scan the QR code on the screen to share your valuable feedback. Thank you, everyone.
All the foreign delegates and speakers, they are requested to be there on the second floor of this building for lunch. All the speakers and foreign delegates to kindly assemble on the second floor of this building for lunch. Thank you. Yeah, this is yours. This is yours.
check. Check.
फालतू का अपन नहीं करेंगे.
Check. 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 Hey, check.
Hello? 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 Mic check. 1, 2, 3. Hello? Hello? Mic check. Mic check.
चेक हे चेक त्याचं वॉल्यूम कमी करून ठेवलं होतं चेक चेक मॅडम
नहीं तुम्ही बोला ना बोला तरी
चेक हे चेक
आप इतना क्यों पास जा रहे हैं माइक के
तिकडनं वाढवा लागेल ना आपल्याला आता येते आवाज
हाँ आता है
चेक आणि तेवढ्या कोपऱ्यात जास्त इथं समोर स्टेजवर यावं लागतं तेवढ्या कोपऱ्यात नसते येत
तरीही
हा इथनं इथनं इतकं इतकं ठीक आहे ना चेक येते ठीक आहे
आता है
check hey check check hey check
फिर से क्या ना
to reach the unreached through medical education and research. And therefore, as the Vice Chancellor, I would like to talk on tribal health through the lens of education, research, and awareness. Guys, thank you once again.
Front runners in achieving
60% pulse on
And because more
we did in
villages, Nagpur school children. So it
primitive driving prosthetic पैदल जात 25 में से एक दो पैदल जाते
So we still have 4 minutes as per our schedule.
check check
only by not just by symptoms, but also by
आपने पूरे ये पर्टिकुलर इसी माइक का किया कि पूरा ही किया? चेक 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 रुको एक मिनट चेक 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 hey check check check
check, 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 check. Hey, check, check, check. Hey, check. Check. Hey, check. Check 1, 2. Check. Hey, check. Check. Hey, check. 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 Hey, check. Check. Hey, check. 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 Hey, check. 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 इसका भी check. Check. Hey, check. 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 Hello. Check. Check. Check test. Hello. 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 Check test. Hello. 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 And test. Check.
Good afternoon. We will soon be starting with scientific session 3, the theme of which is climate change and tribal health, global viewpoint. We have our speakers, Professor Caroline Stephens, Dr. Frederick Theophilus, and Dr. Jetilia Chinyonga, and also our chairpersons, Dr. Abhay Datarkar, Dean, Government Dental College, Nagpur, and Dr. Ujwala Chakradev, Vice Chancellor, SNDT University, Mumbai. We will start the session in 10 minutes. just give you a signal when chairperson is there.
You can start. Welcome back, everyone. So we now begin with the third scientific session for the day. This session addresses one of the most pressing issues of our time, climate change and tribal health. From shifting disease patterns to the resilience of indigenous communities, our distinguished speakers today will offer a global perspective on the challenges and opportunities ahead. I'm honored to introduce our chairpersons for this session, Dr. Abhay Datarkar, Dean Government Dental College, Nagpur, and Dr. Ujjwala Chakradeo, Vice Chancellor, SNDT University, Mumbai. Please help me in inviting the chairpersons to the stage, please. With a round of applause. Speaker, you'll go. Our first speaker for the day, for this session, is Professor Carolyn Stephens from the London School of Hygiene and Tropical Medicine, UK. She will be speaking on global environmental change and indigenous health, challenges and opportunities. Professor Stephens, we look forward to your presentation.
Thank you very much. First of all, I'd like to say that I'm delighted to be here, and I would like to thank the organizers, in particular Dr. Chowdhury, for organizing this amazing conference. I should also say that as a result of climate change, I don't do long-haul flights anymore. So this is the first long-haul flight I've taken in 5 years. The other one was also to India, to a conference on global climate ethics, which I also thought was really important. I also wanted, if any of you have your phones with you, I'm directing this particularly at the students in the room. I wanted to start with Icarus. Could I see a show of hands amongst all of you about whether you know the myth of Icarus that comes from before the British Empire, before any other empire in the world, when the Greeks were ruling the world? Anybody? The idea of Icarus was about human hubris. Human hubris means humans with too much arrogance, people who think that they know everything, who think that they understand everything. And I want to start with Icarus because he created wings for himself, because he believed he could fly to the stars. A little like Elon Musk believing he can fly to Mars, another example of human hubris, perhaps. I want to start with this as well because this shows what we were thinking about over 2,000 years ago. And I want to compare that with what people here were thinking over 3,000 years ago. But I'll start, first of all, with describing my lens. You may wonder why a white British person is here talking about Indigenous health. I've been reflecting on this a lot. I first came to India 40 years ago when I was only 18, and I lived in a leprosy colony in Tamil Nadu. I then moved, after I graduated, to work in Himachal Pradesh. I then worked for the British government here. 40 years later, I'm invited here by the government of India and by the university here to talk about something that I've been working on for the past 20 years. I was asked to work on Indigenous health, and I didn't really think about why I would be doing that. But you may not be aware, but in Europe at the moment, we have a really nasty form of what's called Indigenous well-being, and that's white people all over Europe defining themselves as Indigenous, when in reality, most of us have moved around, been dominated by other people. I come from a Celtic background, so I could say that we were more Indigenous than the Vikings or the Romans. but for thousands of years, people have moved around. The reason I want to mention that is because the concept of indigeneity internationally is highly controversial, and there is no fixed definition of what indigenous means. I'm going to talk a little bit about that, and then I'm going to move on to just briefly touching on the environmental and social context we're living in. I'm not going to give you many statistics on climate change because I believe that most of you should know about climate change. And I believe my colleagues are going to talk about this. I'm going to principally talk not about statistics, but about the way we approach working with Indigenous peoples. And I'm going to focus on impacts of global environmental changes on people with a focus on power. And I want to go full circle and talk about our existential need to actually learn from Indigenous peoples and their wisdom. And I'd really like questions from the students or comments from the students. If you don't agree with me, I'm quite happy. So I'd really like to hear what the students think about this. I'm going to make one final point about learning from history. One of the things I learned when I first came to India, and I should add that as a British person at that time, I had apparently enough education to get me into Cambridge University, but I had never been taught about the history of India or what the British did. This allegory of the blind man and the elephant that comes from 3,000 years ago teaches me that we tend to see things that we're taught without thinking beyond what we're taught. We divide ourselves into walls of disciplines, countries, and nation states in a way that probably isn't helpful for us if we want to address climate change. And I find it really helpful to think about a theory that comes from 3,000 years ago to help us think about climate change. I'm going to make one point statistically about climate change. This is in the context of Donald Trump, a populist leader who has now claimed he's going to drill. Well, I should put baby in the middle of that. The countries most vulnerable to climate change are not the countries most responsible for climate change. That's the first point I would like to make. The second point I would like to make is the Indigenous peoples living in these countries most vulnerable to climate change are also the most affected by climate change. The following point I'd like to make, that maybe you're not aware of this, but in November 2024, the Club of Rome has said that they no longer think that the Conference of Parties, which is held every year to discuss climate change, is useful. They raised this point because the last climate change summit was held in Dubai, which is highly controversial. We also have people and some of the most powerful countries, particularly one powerful country, pulling out of the Paris Climate Agreement and claiming that they're going to go backwards. That means we're actually at a really, really critical moment, and it will affect me because I'm not old enough for it not to affect me. It's already affecting everyone. But it will affect all of the students in this room far more than it's going to affect me. I think we're living in a completely different period. We keep talking about health problems. I've been working for 30 years at the London School, documenting health problems, documenting inequalities. But we've never lived in a period that we would define as Anthropocene. And I can't emphasize this enough. It means that all of us have to change our paradigms, think in a completely different way in the context of that. And UNDP argues, and I completely agree, that this paradigm shift has to be around our human. It has to be about our values. There's a couple of other documents that I think, if you're interested in this theme, that you should have a look at. UNRIST, which is the UN Research Institute for Social Development, produces really, really good diagnoses of what's going on in the world. And one of their most recent diagnoses was around the inequalities in the world and the consequences of those. They believe, and they've documented, that they think that the power of elites that's been called techno-feudalism, the power of big corporate elites that are more powerful than any nation states, is a huge problem for sustainable development and huge problem for social justice. There's another report that came out at the end of the last year, which I also think you should be aware of. The World Bank, whose analyses are not always respected, but they're pretty good at calculating how many people are under the poverty line. I found it completely shocking that in the context of the growth of the elites, we now have 44% of the world's population, that's over 4 billion, under $7 a day. Now, my students in London can barely buy a coffee for under $7. So you have to imagine how people are experiencing that in most parts of the world, and in fact in London at the moment. Even more worrying than that, the World Bank is already seeing 2020 to 2030 as a period where we will make no progress globally on poverty reduction. They believe that this is what one of my colleagues this morning called the poly crisis. Now, I agree completely with that analysis. What I want you to do is have a look at this report, which only came out a few weeks ago. The current poly crisis, argues the World Bank, makes national development strategies and international cooperation difficult. That means that we are potentially seeing, and your First Minister yesterday mentioned that independence is almost 75 years since you were freed from the British. But the UN, the United Nations system that I grew up with, that you all still are living with, is also 75 years old. And there's significant evidence at the moment from political scientists that the UN is under considerable threat. Donald Trump has not only pulled out of the Paris Climate Accords, he's also pulled out of WHO. I'm going to finish with a couple of other points. We're talking about climate change, but the COP28 consensus on biodiversity, and we heard this morning from Dr. Prakash talking about the importance of other species. The joint statement on climate change agreed that we have to address biodiversity and land degradation as well. I'm going to give you some positive news now. Globally, a really interesting paper came out in Nature, again at the end of last year, showing that 70% of the global population are concerned about climate change and are willing to contribute income towards resolving climate change. What's really ironic is the countries facing heightened vulnerability to climate change show a particularly high willingness to contribute. So in other words, the countries like India, who are more affected by climate change, are also more willing to contribute to resolving climate change. One final study, which perhaps you can reflect on. This is an interesting study showing that within countries, and this is a sample from Denmark, India, Nigeria, and the USA, within those countries, a significant proportion of participants that were interviewed in these studies overestimated the average personal carbon footprint for the bottom 50% of the society and underestimated the average footprints of the top 10 and top 1% of the society. Now, the real implications of that means that the rich people are underestimating their contribution to climate change, and the poor people are overestimating their contribution to climate change. The final thing I'm going to mention is that in the context of all of this, there is now a consensus that's parallel to the United Nations system, which you might be interested in, called the Vulnerable 20. The Vulnerable 20 is actually 70 countries. It represents 1.7 billion people, responsible for only 5% of emissions. And what they have done is lobbied to, they're principally finance ministers from these countries. What's interesting is India is not one of the countries in the Vulnerable 20, but all your neighboring countries are. The other interesting thing is that at the moment, all of the presidencies of both the Vulnerable 20, the G77, which has been going since 1964 and was started by India, which represents over 120 countries, all of them are now chaired and have presidents from the Global South. So in the context of this crisis, articulated by so many institutions in the United Nations, I'm going to move on to talking very briefly about Indigenous rights. And the reason I want to do this is because I've been listening to the presentations. I listened to the presentations of the students yesterday. And your esteemed madam this morning mentioned that you've got over 200 studies and you've got very many students interested in working on tribal health. You can take or leave what I'm going to say, but I'm going to make a few comments about humility. I'm going to start with something in 2006, which is why I was invited here. In 2006, the director of my school asked me to help two international NGOs working on Indigenous health. One was Health Unlimited and the other one was Minority Rights. The Lancet then asked us to do published studies, produce and publish studies on Indigenous health around the world. We were commissioned to do that with colleagues from around the world. The only thing I want to point out, and this is the only statistic I'm going to use, is for you to notice that the disparities that Dr. Chang mentioned this morning are across all parameters, but they have incredibly different scales. So this is countries from Canada, New Zealand, Australia, Brazil, India, Uganda, and Peru. Bearing in mind, and I don't think any of my colleagues have mentioned this, but bearing in mind that Indigenous populations are quite often very small, infant mortality rates at this scale can actually mean an existential crisis for the groups. It means that you can actually wipe out a population if you continue to have that level of infant mortality. The other thing I would raise, and you can consider this, is that a more recent publication in The Lancet following our publications argued that establishing the health gaps is very important, but to achieve equitable health outcomes for Indigenous peoples, it's also important to understand how health disparities have arisen and endured. And in particular, not to simply look at the behaviors of Indigenous peoples, but to look at the underlying social determinants of their situation of enfranchisement or racism or stigma. I'm going to mention a couple of other studies where I've worked, which principally has been Latin America. One of the key problems that Indigenous peoples in that region face is exploitation of resources, largely for people who use resources for their own personal consumption. So this is a study of contact, people living in voluntary isolation. Dora was one of my PhD students, and she did some fantastic work. I want to mention this study because this is one of the problems that faces indigenous peoples in that region: exploitation of gas, oil, mining for minerals, deforestation for woods that will be used for furniture for richer countries. But the more important thing is something that one of the Ashaninka leaders said to me when we were going up the tributaries of the Amazon. He said to me, look at this tree. It's a whole world. It has roads, it has its towns, it has its parks, it has its bars, and it has its communities. And he was talking about a tree like this tree, which comes from the cloud forest in northern Argentina. He was talking about ecosystems which are so complex that another aspect of our human hubris is that we are destroying these ecosystems without fully understanding scientifically what we're destroying. I also want to raise one other point that we haven't discussed. We have been talking about indigenous peoples in the global south, but peoples living in the north, in what would be loosely described as Europe, are also facing incredible existential challenges. They're very small populations, and they're having their entire way of life destroyed. With the permafrost melting in both the North and the South Poles. Also, as a result of actions not theirs, indigenous peoples in those regions are actually having their whole lands disappear under them. The final thing I'm going to mention as threat is we were talking yesterday about indigenous wisdom. And I was reflecting a lot on this last night and thinking, actually, one of the real problems we have is that if we lose our teachers, we're also going to lose the languages. And the Permanent Forum on Indigenous Affairs actually believes that the estimates are that we will lose 50% of spoken languages by the end of this century. Pessimistic estimates put this at 90%. It just really depends how fast, particularly AI and new technologies move to make hegemonic languages like English dominate every other language. I'm going to finish with indigenous peoples and technologies. We had an interesting presentation this morning from Dr. Carong about the positive use of technology. And I have worked with indigenous peoples in Latin America who use technology. And in fact, when we were doing the Lancet series, we had video footage emailed to us that was showing damage that people couldn't display locally, but they were able to send to us in London to put into the Lancet. I was asked by Minority Rights Group to do an analysis of the challenges of technology for sustainable development, but I actually think we're already out of date with what we were writing then with the advent of AI. I'm going to finish with a message that we haven't heard, I believe. In the face of extermination, disease transmission, disenfranchisement, exploitation, racism, since the beginning of the climate summits, indigenous people have been at every single summit arguing for everyone. Now, conceptually, I want you to get your heads around that. This means that the people that we've been discussing with great respect as victims have actually been the ones lobbying on our behalf. So this is people in 1992. This is people 20 years after that in Rio again. And this is in the Dubai Climate Summit. And this is a lobbyist from northern India. The point I want to make with that is that I find it really astonishing that the most disenfranchised people in the world, who really have the most contact and the least responsibility for the climate change impacts, are the people who've got the generosity to go to the summits and argue for all of us. The other final thing I'm going to finish on is I work a lot on ethics and human rights, and I'm not going to talk about this at all. I've run out of time, so I'm not going to talk about this at all. But the Human Rights Declaration that was signed again in 1948, almost 75 years ago, was a highly colonial piece of writing. It's highly individual. The UN Declaration on Indigenous Rights is actually around collective rights. It's around people seeing themselves as part of a whole. It's a really ambitious thing about the rights of every single Indigenous person, but it's the rights about Indigenous peoples collectively. I'm going to mention one thing about that. It's in relation to your studies. India is a signatory and has ratified the International Convention, the International Declaration on the Rights of Indigenous Peoples. Those rights, I think you should all read before you start doing your studies, because those rights mean that people have the right to their information. They have the right to the knowledge that you gather about them. They have the right, at a very simple level, for you to feed back that information to them. They have a right to be empowered, not just educated. I'm going to finish on this. 20 years ago, almost 20 years ago, when the International Declaration was signed, Victoria Talley Corpus, who was the chair of the Permanent Forum, said that that day would be remembered as a day when the United Nations and all its member states, apart from 4 at that time, together with Indigenous peoples, reconciled with past histories and decided to march on into the future of the path of human rights. She then said, "We foresee that there will be great difficulties in implementing this declaration because of the lack of political will on the part of governments, lack of resources, and because of the vested interests of the rich and the powerful." And I was listening with great interest to the First Minister yesterday from Goa when he said, "This is the time." And I'm going to finish by just saying that this is the time also when we actually pay huge respect to Indigenous peoples, including all the peoples here in India, for their courage in actually representing all of us with a bit more vision than we have for ourselves. And I'll stop there.
Thank you, ma'am, for such an enlightening and impactful presentation. Now, let's dive into the next presentation of this session, for which I'm glad to welcome Dr. Frederick Theophilus, Senior Physician and Head, Department of Infectious Diseases, University of Sierra Leone, Republic of Sierra Leone, all the way from West Africa, who will shed a light on the harsh realities of climate change in Sierra Leone. Looking forward to hear from you, sir.
Show the power to all of you guys. Good afternoon. I'm very elated to be part of this all-important symposium, which is the FIST-25, right? I was invited by Dr. Chaudhry, and he epitomizes the true spirit of Indian. What I'm seeing has really transformed my life, and I'm going to take the message back home. And also, I have my honorable protocol, Dr. Tobri, who has been very good, supportive to my being here in India. First, Sierra Leone, the former speaker, have already laid the benchmark, right? We are very poor country, and we are clamoring against this devastating effect of climate change. And we just contribute minimal percent to the effect, right, of the world. For brief description, Sierra Leone basically is located on the southwest coast of West Africa, lying mostly between latitude 7 and 10 degrees north and longitude 10 and 14 degrees west. The country is bordered by Guinea to the north, east, and Liberia to the southeast, and the Atlantic Ocean to the west and southwest. We have a total area of 73,250. It's a very small country. The center of this country is a region where we have low plains containing forest, bushes, forest land that occupies 43% of the land area. We have two distinct climates in Sierra Leone. We have that basically helps our agricultural cycle. The rainy season that starts in May and ends in November, and the dry season from December to May. But presently in Sierra Leone, we are experiencing the impact of climate change. Instead of us having Harmattan period, especially the month of January and also February, we are having brief rains with thunderstorms. The population as at 2023 is estimated to be at around 9 million, with a slight female preponderance, with a 48.6% literacy rate. Male literacy rate is significantly higher than female, according to the World Bank 2024 result. GDP in Sierra Leone was 30.34 billion, which ranks my country 154. We have 4 distinct regions in Sierra Leone, right? And we have 16 tribes, right, that are diversely dispersed. We have a designated agency referred to as the National Disaster Management Authority. They are particularly given the responsibility for the management of disaster at the national level. They are responsible for the development of guidelines for the protection of vulnerable people and standard operative procedures. In the case of disaster, despite some progress in the past 5 years, the country is characterized by a high level of poverty, socioeconomic inequalities, especially between the urban and rural areas. That's the map of my country, and we are interspersed in Africa. Sierra Leone is not exposed to volcanic eruptions, typhoons, tsunamis, earthquake, but over the last 15 years, inhabitants of Sierra Leone have witnessed firsthand the escalating trail of destruction left by the wave of droughts, floodings, heavy rainfalls, high humidity, rising sea levels, landslides, and heat wave. The intensities and frequencies of these disasters are not only the decisive factor. Another is a country vulnerability that the previous speaker just highlighted: poverty, corruption, healthcare facilities, inadequate healthcare facilities, inadequate disaster preparedness to these natural disasters. Couple of years ago, that in 2011, Sierra Leone was ranked third liable or prone to natural disasters, according to the World Bank Risk Index report. When I was growing up, I would await the raining season with eagerness because of the sharp drop in temperature that made sleeping enjoyable and fetching of domestic water very, very easy. And my backyard garden blossomed during those days. That I used to make a living from this vegetable garden, right? And we use a lot of plants: crane, lettuce, pepper, cabbage, and some of these plants have medicinal values according to the region they are found. 20 years ago, Sierra Leone agricultural production was booming phenomenally. But for the past 15 years, we have been having some frequent and prolonged dry spells, which have severely disrupted our farming calendar. These have contributed significantly to food and water scarcity and increased the number of cases of waterborne diseases, malaria, malnutrition in children, and also the emergence of previous infection. Like the last time that we got Mpox in Sierra Leone was over 60 years ago, but in recent times we have got about 9 cases of Mpox, and 2013-14 we have an epidemic of Ebola that killed about 3,000 people. There is an area in the eastern part of Sierra Leone referred to as Yenga. This area is very, very rich. The flora and fauna are really flourishing in this area. One of our next door neighbor that borders us on the northeast and drove us out of that land due to its geological richness. This has impacted us negatively in terms of socio-economic development, thus further weakening our fragile democracy due to the frequent insurgencies. The recent past planting season, I'm also a farmer. I had 2 farms, both of which accounted for over 30 hectares of land, one of which was completely inundated with water. All the rice plantation perished. Consequently, I'm going to have a decline in harvest. These are examples among thousands of how climate change is threatening our food security. So this is what happened to one of my farm. When the rain comes, they are sometimes torrential. Floods became more severe due to rising sea levels along coastal lines. They are also more frequent. They are more frequent in the past 3 to 5 years, right? Now hitting us every year. These have resulted to the destruction of houses recently in the capital city, Freetown. A 7-story building collapsed. Mud houses swept away, resulting to loss of lives and property in a financially challenging society. Street floods, crop damage has become part of our everyday occurrences. These floods also contaminate drinking water and lead to the spread of waterborne diseases such as cholera, typhoid, and other diarrhea diseases. So this is what happened: collapse of a 7-story building, capital Freetown. We have precarious housing, right? The increase in flood coincided with land use changes and had a rapid population growth, because 30% of the country population resides in Freetown. The land use changes has shifted completely from building in low-lying safe areas to building in mountainous areas, slopes of hills, wetlands, and waterways. This is particularly pronounced in Freetown due to population outburst. A recent questionnaire carried out by the Sierra Leone Meteorological Agency showed that the people in these disaster-prone areas are in a constant state of anxiety and depression for their homes not to be destroyed, right, or damaged by climate change. The Ministry of Health conducted a mobile survey in 2023, documented a twofold rise in blood pressure in people inhabiting these disaster-prone areas. Coastal households are now significantly impacted by sea level rise when foundations are weakened or the infrastructure itself damaged. Flooding for all of us in that country is now a red alert. Widespread expansion, not limited to the coast, but also to the mountain tops and foot of hills. In the capital, mass deforestation, construction on wetlands and forest reserves, coupled with torrential rain, saturates the soil. This triggers rapid movement of rain or debris, causing landslide and mudslide. Now, unfortunately, we the inhabitants are accustomed to mudslide and landslide. August 14, 2017 is a day that all Sierra Leoneans will never forget, making one of the worst natural disasters in recent memory. We have intense rainfall, triggered a massive mudslide and flash floodings. Due to the intense overcrowding in this dense cluster of homes onto which each side collapsed, over 1,000 people were killed and many more were gravely injured. Over 3,000 people were displaced. The economic impact cannot be quantified. So this is a pictorial diagram of what happened on the 14th of August. We have floodings coming out every year. The diverse impacts of climate change have over the years severely affected the economy of my country and changed people's life and livelihood, such as we are predominantly farmer, but over time, people have moved to other activities like stone mining, motorbike riding, for commercial purposes, right, for income generation. These coping strategies are not only insufficient, but also dangerous. What can we do to tackle some of these realities, right? Despite we are only contributing a minimal percent to the overall climate change activity. So it requires a strategic and holistic approach, addressing both immediate challenge and long-term sustainability. There are several essential strategies that the designated agencies, that the NDMA and the Environmental Protection Agencies have coined out. We are looking at strengthening resilience, wherein we are going to fully engage the community, talking to chiefs, talking to council of elders and youth leaders in our community so that they will be part of the project, right? Despite climate change affecting them, we are going to make them feel and see the need for them to participate in tackling this effect. So it's going to be community ownership. So that will definitely drive, right, the zeal and aspiration to tackle this effect. Also, they have put forward a diversified livelihood. Farmers, those involved in agriculture, are encouraged to diversify their sources of income due to vulnerability to climate impact. And recently, farmers are getting heads up in sustainable farming techniques which can produce more food. The government is also investing heavily in infrastructure by building resilient structure, for example, bridges, roads, and also people are encouraged to have building permits, and also there are policies where you should construct your houses to prevent this unwanted mayhem. They have also coined out ecosystem restoration, right, by reforesting and afforesting. Governments and partners, including the business people, such as banks, have invested heavily in projects such as Stop and Plant a Tree to restore degraded ecosystem, which can enhance our carbon sinks, protect biodiversity, and reduce erosion. They have also involved in what? Mangrove restoration, right? Government of Sierra Leone is protecting and restoring our mangrove plants along the coastlines, right? It's always serve as barriers to rising sea level, but also serve as habitat for fish to reproduce. They have also talked about disaster risk reduction by having emergency preparedness. So there are policies that have been put in place in areas where we have high incidence of disaster. For example, the community that's referred to as Kube, one of those that I showed earlier. And also early warning system. The NDMA and EP have developed and gradually implementing the effective early warning system for extreme weather events to allow communities to prepare and respond appropriately. Water management. It interests you that Sierra Leone, that over the years we have immense source of water, but most of our rivers drying. So they have now implemented sustainable water practices. This is primarily put forward by the Ministry of Water and Sanitation, where we are going to harvest water and have conservation policies, right? This will soon be rolled out, especially to prevent or to target drought regions. They have also developed efficient irrigation framework in the regions of the country where leafy vegetables are cultivated. This will help to ensure consistent agricultural productivity amidst variable rainfall patterns. So, since I have the opportunity to talk to people all around the world, we urgently need governments of nations right across the world. We're a very small nation, an international organization, and people of these nations to take leadership on the issue of loss and damage. My country, as with other least developed countries, need dedicated financial support to help address the profound and far-reaching damage and the deep irreplaceable losses. Thank you very much.
Thank you, Professor Theophilus, for that thought-provoking talk. We now move on to the final talk of this session. To deliver this talk, I would like to call upon the stage Dr. Jelita Chinyonga. Our speaker, Dr. Jelita Chinyonga, is former director at the Ministry of Health, Zambia, and she will be discussing on the intersection of climate change, traditional medicines, and health in the African subcontinent.
Good afternoon, everybody. I just want to thank, before I begin, to thank the organizing committee for giving me this opportunity to present at this first international conference. It's indeed a rare honor and privilege. Thank you very much, Dr. Sanjeev Chaudhry and the organizing team. So I have traveled 7,800 kilometers to come to be part of this very, very huge milestone. So before I go, Before I go into my presentation, which is talking about intersection between climate change and traditional medicine and health in the subcontinent of Africa, I just want to give you a short little story about traditional medicine. So there was this lady who had 7 children, and every time the child was born, they would be given some concoction and they would be put some scarification marks on the chest. So she had 7 children that never saw the inside of the hospital. 4 of them were girls, and they only saw the inside of the hospital when they went into labor, and one of them is me. I was admitted in the hospital at 26 when I went into labor. So I think I just want to stress on the importance of traditional medicine. So my presentation outline is I'll give a brief introduction and then go into climate change. I'll talk about traditional medicine and health, and then we'll look at the intersection of the three. And then we'll look at the response in Africa. What are we doing in Africa? What are the major challenges, the challenges and opportunities, and then the conclusion. So this is the Africa that we know, or this is the Africa that we knew. Very beautiful, full of green vegetation, full of waters, the rivers were full, and we had people that were going into the forest to choose as many types of medicines as they wanted. Those are the traditional healers that were going into the forest to choose whatever medicine that they wanted. So what is happening now? We have climate change. And according to the UN, climate change is a long-term shift in temperature and weather patterns caused by human activities. I think what we need to stress on is that these are caused by us as humans and many burning fossil fuels. That is according to the United Nations. And as earlier mentioned, in Africa, climate change is threatening the lives of over 1.5 billion people. And again, we all know that as Africa, we contribute very little to climate emission, but we are the ones that are most vulnerable. We have droughts, we have floods, we have heat waves, cyclones, and everything that is affecting us. But as earlier mentioned again, we contribute the less. So what is climate change going to do? It's going to push about 132 African people into extreme poverty by 2023. And we know the effects of poverty. It will just take us backwards to where we were. And over half of those are in sub-Saharan Africa and in Asia. At least 44 million will be driven by health impacts. So that is what climate change is going to do to us if we do not act now. So traditional medicine, according to the World Health Organization, is the knowledge, skills, and practices based on theories, beliefs, and experiences indigenous to different cultures, used in mainstreaming health and preventing diagnosis, improving or treating physical and mental illnesses. And that is according to the WHO, the World Health Organization. So it's tribal health, it's traditional medicine, traditional complementary and alternative medicine, and it's been there for years. Even before modern medicine came in, we had all those medicines that we're using. So one of the key characteristics is that it's deeply rooted in our culture. Tribal medicine, traditional medicine, it's all culture based. And it's based on knowledge that is passed on from generation to generation. I feel sad that I didn't get the formula that Mom used on us. And it's something that we need to learn now to start documenting and getting the information that we need. And I was telling myself that I should have spent more time with that lady yesterday that is healing snake bites. And then we also know that it's the oldest form of treatment and it's holistic. It looks at the general body, the mind, and the soul. So once you go traditional healer, they're going to look at you as a whole. So, sorry, am I going back? Yeah. So again, as I said earlier on, it complements conventional medicine. According to the World Health Organization, in Africa, we have over 80% of the people that are seeking traditional medicine. And before it was like traditional medicine was only for the rural area, but now we have people from the urban areas going to look for the traditional healers so that they can get medical attention. And the other advantage of traditional medicine is that it's easily accessible. In Africa, we have a concentration of health facilities in the urban areas, whereas in the rural areas, access is very, very limited. So you find that people have to travel hours and miles. So we don't only look at the distance, we measure the distance in kilometers and also in time. Because sometimes even when you have a vehicle, a journey of 50 kilometers will take you so many hours because of the bad road network, as we also saw in the other presentation. So traditional medicine is easily available and accessible in the rural areas, and it's affordable. Sometimes a traditional healer will just ask you to come with 1 or 2 chickens, which is easily available. And then there's also the aspect of there's community-based care. So you don't have to travel to another facility. And we know the cost of what happens when somebody's admitted in a hospital. Everything changes. The whole family is spending the time at the hospital. They have to spend transport there. But this one is community-based and everything is done at home. And then it's the source of drugs is medicinal plants and a few microorganisms. So that's the part of the traditional medicine. And it's also a source of income. So what about health? As WHO states, it's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infinity. So when we look at health as a whole, we are looking at the total person. Are we okay mentally? Half the time I always joke and say most of us have mental problems, but we are not talking about them. But WHO is saying that it should be a complete state of physical minds. But when you look at healthcare in Africa, the systems are already facing serious challenges. I think you heard from the other presentations. And even what we had started gaining before, we are going backwards because of climate change. So currently there is some improvement. The life expectancy has slightly improved. And even the indicators such as skilled birth attendants have slightly improved, but we are being threatened by climate change, which affects mostly the social determinants of health. So this is a CDC a diagram showing the impact of climate change on human health. So when you look at those issues, most of them have already been discussed, but we are looking at the injuries and the fatalities we saw from the pictures from Sierra Leone. We are looking at the respiratory diseases, those were already mentioned. We are looking at the zoonotic diseases. We're looking at the malaria increasing. We had almost gone down to eliminating malaria, but we are going back, seeing an increase, and then respiration. Then we are talking about cholera. Malnutrition and diarrheal diseases are not left out. And even when you look at the impact of climate change, people have lost their houses, they lose so many things, there's no water, so they are forced to move to where they can get these facilities. And then we also have the heat and heat-related illnesses. So it's just a whole confusion, and it complicates the health system more. So that is according to the CDC. Then now when we are looking at the intersection, we are looking at when climate change and traditional medicine intersect, what happens? So already we've talked about the extreme weathers that are affecting production and potency of plant-based medicine. Remember we said that most of the medicines in traditional medicine are found within the forest, within the whatever is surrounding us. But when we have those floods and droughts, then we tend to lose all those. And then the increase in climate-sensitive diseases. And then we also have a change in treatment patterns, because if we are going to treat diarrhea with a particular tree or root, and that is gone because of the drought or because of the heat, then we have to find another alternative. Maybe we may not find the alternative, so we have to think of what is it that we are going to use to treat this patient. And then there's even a strain on traditional medicine. All those issues, if I can't find this, I can't find that, that is straining the traditional medicine that is complementing the the modern medicine. And then, as I mentioned earlier, there's displacement and migration. So when you are moved from where you are used, mental health issues come in. We have issues of gender where we know that women are abused sexually or whatever it is. So all those are issues that affect the climate, the part of the medicine. And then when you look at climate change and health, as we saw from the diagram, the social determinants of health are affected. Everything, the water, the sanitation, electricity, energy, and all those affect health. So all those are affected. And of course, we expect a lot of problems. I did mention the increase in the vector-borne diseases, the malnutrition due to food insecurity. We saw from the previous presentation, the doctors' fields were gone. And then we also have reduced access to health services. So if the bridges or the rivers are flooded and the health facility is somewhere where you're supposed to cross a river, what used to be a stream now is a big river that is impassable, then again, that again affects the health services. And we talked about the migration. And sadly, it's already affecting the already weak health systems that we have. So instead of going forwards in strengthening our health systems, we are going backwards because of climate change. So traditional medicine, again, and health, we said it's holistic, and then it complements modern medicine. As I mentioned earlier also, it increases access, and not forgetting that it's also a source of income. And when people are empowered economically, they're able to contribute to social economic development. So when the three of them intersect, this is what happens. We talked about the climate change that is affecting the health and environment, and also the potency of the medical plants, and then it also threatens community care. I know we don't have enough facilities, and we do believe in community care, and it slows down socio-economic development in the communities that we live. So this is just a diagram that is showing the intersection. I think the most important part is that we are all trying to follow the SDGs. We are talking about health and well-being, economic development, but when these three intersect, there's reduction in production, there's reduction in socio-economic development. So again, it's taking us backwards, and we can't go forward in terms of illnesses, in terms of health-wise, in terms of economic development and all the other issues. So what is the response? What has Africa done to respond to this? We are mostly looking at SDG 3, which is talking about good health and well-being, and SDG 13, which is talking about climate action. So from the pictures, you can see a lot is going on. The strategic plan has been developed. The other picture is showing the heads of states meeting at the summit. What are we going to do? The other picture is showing the technocrats meeting, and the community is also saying we can't be left out. We need to participate. We need to do something to make sure that we mitigate the effects of climate change. So those are the pictures that are showing that everybody, leaving no one behind, we are all participating in mitigating climate change. So some of the issues that are taking place now is at national levels, at different countries, there are established interagency policy task forces. We know it's a multi-sectoral approach, not only the Ministry of Health, not only the Ministry of Defense, not only the Ministry of Agriculture, everybody's affected and everybody has to take part. So there's a lot of interagency policy infrastructures that are being created. The task forces are being created to make sure that is done. And then there's also the development of national adaptation plans. Quite a number of countries in Africa have developed these plans to make sure that they adapt to climate change. And then we are also looking at supporting low emissions development strategies. What are we going to do? Where there's drought, where there's no power. Like in my country, we were supplying power to quite a number of countries. We have the man-made lake, which is called Kariba, but now the levels are so low that we are affected by the load shedding. We are also exporting to other countries. So we are saying, what is it that we are going to do? So we are trying to move to solar. What are the other alternative sources of energy that we can do? And then at least 40 countries are implementing the ecosystem-based adaptation for food security assembly. So this guideline is talking about looking at alternative strategies. What do we do when we have floods? How do we make sure that we are food secure? When we have drought, how do we make sure that we are food secure? So what other strategies can we employ to make sure that we are food secure and not run into malnutrition? Going backwards. Okay, sorry about that. So these are all the responses to climate change in Africa. So we are looking at how do we make sure that we are climate resilient? How do we make sure that we mitigate the impact of climate change? So one of the good things is that by November 2019, 49 out of the 54 African countries had ratified their national determined contributions to climate change. So meaning that those countries have set aside a certain amount of money to contribute to mitigate climate change. So on traditional medicine, yes, we have said it's been there before, but what else are we doing it? So in 20,000, the ministers of health under WHO met and adopted resolutions to say traditional medicine should go on, it's the key, and it should be promoted, it should be integrated. So over 90% of the countries in Africa have traditional medicine policies, meaning that we are integrating traditional medicine with modern medicine. So a study that qualified medicines. So 89 medicines were put in the study. So out of those 89, 43 qualified, and now they are found in the essential medicine lists of certain countries. So normally you have the essential medicines lists that have Western medicine, but now 49 of these are traditional medicines. So that's another way of promoting traditional medicine. And then the WHO in 2003 declared an African Traditional Medicine Day that we are celebrating every year. Ghana, Mali, Benin, and Nigeria have integrated traditional medicine into healthcare, and I think South Africa has also done the same. So on health, as I mentioned earlier, we're already struggling with weak health systems. But again, we are also consoled that COVID exposed a lot of us, including the developing nations. We all noticed that we had weak health systems, but though everybody was affected, Africa is still worse. So by 2022, we had 46% of universal health coverage, financial protection that reduced. So what we are saying is that we shouldn't spend out of pocket when we are sick. We should have financial protection to make sure that anytime we are sick, we can access medical services. So we are talking about health insurance. Other countries have free medical services, especially for critical programs like primary health care, to make sure that we cut down on the number of that are falling sick and contributing to economic development. So on the service coverage indicators, in 2002, we were 24%, but we've gone up to 46% in 2019. But then again, we shouldn't relax. We still need to do more. Out of all the continents, Africa is still the lowest. And then we are looking at what are we doing as Africa. There's Africa Agenda 2063, and this is talking about the Africa we want, and it's mostly looking at the SDGs, and one of them is saying we need to improve the health and well-being of the population. So, am I going back? Yes. Sorry about that. So I did try to come up with major challenges. Of course, the challenges are more than this, but I thought we'd just talk about a few, and then we'd also look at how we are mitigating the opportunities that we have. So we're looking at low levels of economic. We've talked about poverty. 2/3 of the people in Africa are extremely poor. We talked about food systems and security. We talked about, in others there's lack, in others there's inadequate energy and infrastructure. And then we talked about reducing biodiversity and wetlands. And then there's a poor city planning. I think when you look at the pictures and what is happening, the buildings falling down, infrastructure, we are not planning our cities very well. And transport mobility, according to the AU strategic plan, we need about $3.2 billion to repair infrastructure and maintenance and look at issues of research and innovation. And as we are looking at changing, we're talking about using electric vehicles. That's what we need. And then we are losing a lot of water systems. 1.2 billion in Africa risks being negatively affected because of the water systems that we are losing. We are talking about blue economy. Look at what is happening to the lakes, the rivers, the seas. I think we are losing what is there. And then we also have weak governance in climate information systems. We're not talking about it properly. So I try to summarize just to look at a few challenges and opportunities that we have to address these challenges. So when we looked at the issue of poverty, we're talking about, we have the opportunities to develop funds and climate funds mechanism to make sure that we are looking at the global climate funds so that we address and mitigate the impact of climate change. And then we're looking at the food systems, food security. Malnutrition is already there, and with climate change, it's going to increase. So what we are looking at is the opportunities that we have. We are looking at climate sensitive farmers with knowledge and ICT, and they have the ability to select climate resistant crops. If it's in drought areas, let them choose the crops that are drought resistant, and where there's a lot of water floods, let them choose crops that can manage in that. And then we're talking about investing and restoring in ecosystems, off-grid and smart grid solutions, looking at renewable energy. Are we putting solar panels? Are we putting any other windmills where they can work and all that? And then we looked about implementation, international climate change regulatory framework and adaptation plans. So I'm running out of time. If I'll be allowed to run through. Sorry, yes, I need to end. Okay. So in conclusion, I think we are saying the intersection is a major area of concern. We all need to be concerned because we need to understand climate change, the impact it has on traditional health and the impact it has on health, so that once we understand it together with the communities, we can plan on mitigating all the effects. And just to say that the journey from Africa is far from over, but that doesn't mean that we can't make it. We will definitely make it. And then I just want to end with one of the quotes from, I think, our own Indian environmentalist, Dr. Vandana Shiva. The health of our planet is the health of our people, and we must protect it. So on the two pictures, I have the picture of the Victoria Falls. I think this is one of the 7 natural wonders of the world. So the top picture is showing what climate change has done when there's no water, and then the second one is showing before the climate change what it was. It's also called as the smoke that thunders. So with this presentation, I just want to thank you for your attention.
Thank you, ma'am, for such a thoughtful and engaging presentation. I now request our esteemed chairpersons to grace us with their wisdom and perspective on the topic.
Hello. Thank you so much. Uh, since morning, I've been listening to so many presentations talking about the climate change now, but then about the medicines. When I got the call from Dr. Kanitkar madam and Chaudhary, Sanjeev Chaudhary sir, and I was wondering why. I instantly said yes, of course, but I was wondering why am I here? And now I know why I am. And I believed her actually. And then I thought, Professor Caroline, Professor Frederick, Professor Jelita, three of them have emphasized on the various aspects of climate change, which are so important and probably we knew, but combining them together brings back to us some pointers to think about what exactly we need to do. And probably that's where me as, and along with you all doctors, probably could take it further. Climate change is affecting all of us, the entire humanity. But you know what happens to the tribal people is more important. It's like पहले ही करेला और फिर नीम चढ़ा is something which we say, but for my other friends who would not understand this, it's affecting the entire humanity, climate change, but it is worse with respect to tribals or tribal people. So how is it that the various aspects were put forward by three of the speakers here? The values, the lifestyle, the customs, the microclimate of each tribal person, community, locality is different. So is there that of the India. We have to understand it first before some interventions can be done. While during lunchtime, Dr. Kanitkar said that it is the social interface that's more important. And when doctors are thinking about treating these communities with their peculiar diseases and which are very common to them, then how do we deal with it? Dr. Jelita, when she talked about these medicines of her community, of Africa, and deeper inside the forest, I remembered my grandmother, talking about some medicines, bringing out those, telling us to use those. And I remembered not only those things, but there are three beautiful words which are associated with the entire being of tribal communities in India, and they call it Jal, Jameen, and Jungle. So Jal, Jameen, and Jungle, that is water, land, and forest, they constitute the entire tribal community. And they have their own meanings to that. Three stories come to me. I'll cut it short, but within one sentences, because that would narrate everything or summarize everything that was told by our speakers. One story is which I experienced when I was traveling to the tribal area here near Chandrapur. And when I was going in my taxi, there was a person who was a tribal boy who was escorting me. And when a beautiful forest on either area, side of the road, and there was one gooseberry, that is aula plant, and there were lots of berries on the ground. I asked the driver to stop the car and I said, please pick up few. I would like to have those. And the boy ran and brought 2 gooseberries for me. I said, only 2? Why couldn't you get few more? How many you want? His question. I said, I want handful. How many would you eat? I said, 1. Then have 2, was his answer. And that was a moment of learning for me. Another moment of learning, which I heard from my colleague who was working for these tribal people, so-called, he was working for them.
He was in the village, not village, I would say a land, where there was a small hut where this person was staying, and he spent the night. In the early morning, he asked him, the minimalism to its peak, there was nothing in the hut where they were living, he said. But in the morning when he got up and came out of the hut, the entire land, he said, how much do you own? He said, I plow this much of land. And he gave a huge expanse. So my friend thought he's a rich man. He owns such a land. So he said, do you own it? I said, no, how can I own it? It's God's land. How can we own a land? So the commitment that land is not mine, I cannot own any land, is something which he said I learned from him. So is the story of the forest, which was before British came to India. The forest was owned by a community and they used to reserve it. Even now we have Dev Rise, that is forests which are owned and guarded by gods. And these forests were taken up by the government saying that you cannot protect it, we will protect it, and you have to pay us the tax for that. So with this kind of a thing, all the forest came down and the entire values, education, and the way of living of these tribals probably is fading away, waning away. I think that's where the educationist role comes in. The educationists need to make a proper education right from small children to the higher education at a various levels, where awareness about the values, the way of living, the importance, it's not always that we will want to bring them to the front line, but we want to learn what they own it, what they have. So appropriate mixing up and mingling up of the communities together, educationists and they together, as well as we need to have harnessing our own thoughts, ideas, documenting, as very rightly said by Dr. Jalita, that documenting the medicines, the ways of lives, their beliefs, their way of architecture, their way of living, their many things come together, and probably that will teach us how to deal with our lives and how to make us more responsive to the climate, to the things which we are doing, and then probably we would not be questioning why we are doing climate change conferences in most air conditioned and controversial, in not only the venues but the places would be something. So when I intervened and talked with the Commission for Climate Scheduled Tribes for India, and we also discussed the all these issues. So the stories which I narrated were only 3, but there is a book, entire book compiled by them, where such many stories are there, and these need to become the mainstream education all the schools, at all places, but at the same time, these need to be documented, and there has to be a technology intervention, as has been mentioned right from the morning sessions. So in technology intervention, we can have a common dashboard, a platform where all these peculiarities all across the globe of these tribes could be documented, learning from each other, commonalities which could be taken up and addressed particularly. So I'm not great enough to give any advice to doctors, but I would definitely say you are doing a great job by dealing with the medicines and the medical, healing them. But at the same time, while doing so, they have some peculiar things. If something can be exchanged and learned from them, probably that would be faster, because the roads and the infrastructures to reach to the medical hospitals could probably be would take a longer time. So understanding their ways of healing could be brought into the mainstream line, as was done, and maybe WHO could be made or convinced through the research that this is what can probably be the part of the mainstream medical treatment also. Some of those, of course, after a thorough research, after you all are convinced that it could be done. Like many of our Indian words, guru for example, now has become the part of the dictionary. So our medicines, traditional medicines could be a part of the general medicines also probably could be there. Thank you so much for giving me this opportunity, a great session for me to learn so many things.
First of all, I congratulate three speakers, Carolina, Frederick, and Jalita, for putting up this particular very difficult topic in a very simple and the way everybody must have understood. They spoke about the different reasons for the climate, the global environmental changes, and the indigenous health. What is the importance of indigenous health? How they are proportionately related with each other, the poverty and the climate, and the climate and the poverty, and what are the solutions for that? Like, we all should come up with a strategic planning to reduce these natural calamities so that we all can come up with the dream of what we call it as a Vasudhaiva Kutumbakam. And Jalita, she spoke very well about the traditional treatment with the modern approach. Whatever the modern approaches are there, they can be integrated with the traditional treatment, and that will definitely help us to come up with the better treatment modalities. Lastly, climate protection and the health restorations, these are all the responsibilities of all of us. I congratulate all the three speakers. Thank you.
Thank you, sir. Thank you, ma'am. Your words made the perfect and grand conclusion to this session. I would now request our chairpersons to felicitate the speakers of this session and request the esteemed speakers to come up on the stage for this felicitation. Professor Carolyn Stephens from UK. Dr. Jalita Chinyonga from West Africa. Thank you, ma'am. Professor Carolyn Stephens from UK. Thank you, ma'am. Dr. Frederick Theophilus from West Africa. Thank you, sir. Thank you, sir. Thank you, ma'am. I now like to invite Dr. Naira Krithian, psychologist, Republic of Armenia, and Dr. Precious Nairambi, CEO, Vessels of Virtue, South Africa, to felicitate our esteemed chairpersons, Dr. Abhay Dattaka and Dr. Ujjwala Chakradev. That brings us to the end of the third scientific session of the day. Thank you, everyone.
We would now move on to the most awaited session of the day. Yes, it's the panel discussion. The theme of the panel discussion is genetics and tribal health, reshaping perspective. To moderate this panel, I would like to call upon the stage the moderators, Dr. Kuldeep Singh, Professor of Pediatrics, AIMS Jodhpur, and Dr. Aarti Kinikar, Professor and Head Department of Pediatrics, Vice Dean, BJ Medical College, Pune. Please help me in welcoming the moderators to the stage. For this panel discussion, we have 4 panelists, and I would like to invite all the panelists to the stage. Dr. Partha Majumdar from National Science Chair, Science and Engineering Board, Government of India. His area of interest is genetic heritage of indigenous population. Welcome, sir. Would like to request all the panelists to come up to the stage. The second panelist is Colonel Uday Yanamandra, Professor of Hematology, Armed Forces Medical College, Pune, India. His area of interest is the sickle cell disease burden and experience. The third panelist for the day is Dr. Mitali Mukherjee, Professor of Bioscience and Bioengineering, IIT Jodhpur, India. Her area of interest is the potential of genomics for tribal health. The fourth panelist for this panel is Dr. Debyajyoti Chakrabarti, Principal Scientist, Institute of Genomics and Integrative Biology, New Delhi, India. And his area of interest is navigating the translational route, genome editing therapy in resource-limited setting. So all the panelists would have 3 minutes to offer their opening comments and start the deliberations, following which I would request the moderators to moderate the session and take the questions from the audience as well.
Good afternoon, everyone. And as we know that the tribal health is becoming important, it was important, and it has now more connotations with the advent of the genetic technologies. Genomics is changing the world in which we see, and we can trace to the past, from the past to the future. And recently with the Genome India mapping, which is a reference map of the human genome of the 10,000 population, which include the tribal population also, It will pave way for the new emerging technology which can help the tribal people. But there is a lot more to learn about the genetics and the tribal health. I am Dr. Kuldeep Singh. I am professor and head of pediatrics and former dean, first dean of AIMS Jodhpur. And I am also managing the tribal health area, 260 kilometers from AIMS Jodhpur in the Sirohi district. And we use all these technologies like drone technology, telemedicine, and the tribal healers for their care. We also are the center of excellence for rare disease, where we manage and give the financial benefit to the patients suffering from the rare disease up to 50 lakhs per each patient. And also we are looking for the screening program for the community level. And I think this is the most important thing, that we go to the community to find out the genetics disorders and also provide the antenatal diagnosis, so that ultimately we can prevent. Although we cannot eliminate the sickle cell disease, but there is at least we can take this effort to provide the more help to the people in the tribal area. Together with me is Dr. Aarti Kinikar, and she is a professor and head of BG Medical College, Pune, and she has a specialization in the area of social and pediatrics, and she also looking after the tribal health. She is also fellow of the Indian Academy of Pediatrics and also vice dean. She has many publications to her credit. She is also doing the research in the various areas of the child health, including the neonatology and the tribal health. So with this, I would like to invite Dr. Aarti to pinpoint the objectives of this session.
Thank you, Dr. Kuldeep. So as all our panelists have been introduced to you already, I welcome all of them once again to this panel. So if we start with Dr. Partha sir, everyone in the hall knows sir through all his YouTube videos and his excellent combination of what the genetics and statistics can do to this country. So we hope to hear a lot from you, sir, about your expertise in these two fields. We have Colonel Uday, but I can't see him around, but he is one of those dynamic persons from AFMC as the leader in hematology, and he has worked very closely with Dr. Kanitkar ma'am on a sickle cell project in Nandurbar, and he was supposed to present it. I think he was left for Wardha. We are waiting for him to arrive. Then we have Dr. Mitali Mukherjee, who is an Ayurvedic person interested in genetics. So ma'am, we would love to, actually you have a very scientific background into genomics, but interested into the Ayurvedic aspects of it. And last but not the least, the modern man with a lot of genetics added to it, and how we can take forward in the implementation part of bringing the treatment to the indigenous people who really need it. So this is the Indian profile, where we have nearly 8.6% of our national population, which is amounting to 104 million, comprising as our indigenous people or the tribal. We have 705 ethnic groups which have been categorized by the government as scheduled tribes. And we have already heard people and the speakers in their expertise talking about the challenges in relation to their health issues, and especially the non-communicable diseases which are rising. To start with, I would just like to say what this panel discussion aims to bring about. The first one is, how do we see the role of genetics in understanding and addressing the tribal health challenges? The second aspect which we expect to come out of this panel discussion is that these tribal population are staying in isolated areas, endogamous, and how does this local context, like if you saw the belts in India, there are different parts. Main belt is in the center, the northeast, and the north part. So in relation to that, does it make any difference in their genetic makeup and make them prone for the risks of the changes in the climate as well as their environment. The third aspect is the ethical and logistical challenges in conducting genetic studies among them. And last but not the least, the genomic research, which we have been talking about since yesterday. How can it be translated into tangible health benefits for these communities, and also with deliverables which are stage-wise, which can be done in the short term, long term, and also sustainable. So with this, I will hand over to Dr. Kuldeep to take our first panel questions, please.
Thank you, Ram. So the first round will look into the understanding the genetic landscape of the tribal populations in India. And as we know that there is a wide spread tribal populations in India from north to south and from east to west, and they have a different type of genetic makeup also. I would like to start with first question from about the genetic heritage of indigenous population from Dr. Partha P. Majumdar. I would like to tell something more about him. He is the National Science Chair of Science and Engineering Board, Government of India, and he is the fellow of all the science academies in the India. He is also the technical advisory committee member for the Genome India project, so which has saw the huge potentials in the coming futures and the call for proposal for further research into this area. He is also having many of these awards from different areas around the globe, and is also the chair of the Ranbaxy Research Award in the Applied Medical Science and Ranbaxy Science Foundation, New Delhi, and New Millennium Science Medal by the Indian Science Congress Association and the Council of Scientific and Industrial Research, Government of India. So, sir, I would like to know about what is your view about the genetic heritage of the indigenous population? The first question is, what unique genetic markers have been identified in the indigenous population and how they inform our understanding of the disease susceptibility?
Good afternoon, everyone. Thank you, moderators and my panelists here. We are talking about tribal populations. The first point that I will make, or the first statement that I will make, is that the tribal populations of India are our ancestors, and we must respect them and treat them well. We have not been treating them well, and that's the first point that I would make. How do I justify this? One of the things that we know today from various kinds of research, fossil-based research, paleontological research, genetic research, is that we all evolved in Africa. All of us owe our roots to Africa. We evolved in Africa about 100,000 years ago. We came out of Africa and we spread to other parts of the world. One of the first places that humankind came into is India. So India harbors some of the oldest populations next only to Africa. Within India, if we look at the genomic diversity of various communities, including the tribals and other communities like the castes and other groups that we have, it is quite evident that the maximum amount of diversity that we see are among the tribal groups. And from that, we infer that the tribal groups are our ancestors and they are the oldest communities, because a population that actually has evolved for the longer period of time will have accumulated a larger amount of genetic variation. So in a community where you see a large amount of genetic variation, the inference that you can make is that if there is a large amount of genetic variation, that particular community must be the oldest. So, we've done over decades, we have done with increasing amounts of sophistication, we have done various kinds of genetic research, and there is no doubt that the tribal communities are our ancestors, and they are the oldest inhabitants of India. They also, we have heard in the morning, they are usually small, endogamous groups, meaning they marry within themselves, and they live in secluded places, so it's not easy to reach out to them. If you look at the current disease profiles of the tribals, for various reasons, probably because of their seclusion and probably because they adhere to their own kinds of culture, it's not been possible for modern medicine to reach out to them in ways that we should already have reached out to them. That has been a problem. Infant mortality rate is very high, etc. One of the questions that's displayed here is what unique genetic markers have been identified. You can never identify unique genetic markers. We are a continuum. We are an evolutionary continuum. There are no unique genetic markers among the tribal populations. The same genetic markers that we have, the tribal populations also have that. As a matter of fact, the original genes or the original alleles, as we call them, they evolved in the tribal populations and we have inherited from them. In the morning, there's a lot of focus on sickle cell disease, and as a matter of fact, many of the tribal populations, especially in central India, central and western India, they have high prevalence of sickle cell disease. And we've also heard this morning that it's not just the sickle cell disease, but the sickle cell disease manifests itself in various ways. There are shades of manifestation of sickle cell disease, and this depends on the haplotypic background. The haplotypic background of the tribal populations and of other populations where there is sickle cell disease is predominantly the Arab India haplotype. In the morning, we have heard about the Benin haplotype. The Benin haplotype, as a matter of fact, is associated with severe forms of sickle cell disease, while the Arab India is relatively milder. So what we have in India is relatively milder presentation of sickle cell disease compared to Africa. What is unknown is that it's not just the vaso-occlusive crisis or the hemoglobin disorder, but it also, sickle cell disease also afflicts various other organs. And very little is known about, the reasons for manifestation of other organs or why other organs are also involved in sickle cell disease. And a lot of work needs to go on with respect to that. With respect to talking about the tribals, so for example, among the tribal populations, the reason why I believe that we have not treated them well is because if we just restrict our attention to the to sickle cell disease, there are no ways of surveillance of sickle cell disease among them. We just don't have the appropriate wherewithal to be able to find out who carries the sickle cell gene and who does not carry the sickle cell gene. Once they carry the sickle cell gene, they also need to be appropriately counseled, and we just don't have the health facilities among the tribal belt or within the tribal. Again, the one reason why we don't have that is because they live in remote places, secluded places. But again, being our ancestors, we must reach out to them so that they don't suffer the way that they're suffering today. I will stop here for now, and my answer to the question that's displayed is that there are no specific markers of the tribals. It's just the frequencies of various kinds of genes that are different among the tribal populations compared to the caste populations. Many of the tribal populations with respect to sickle cell disease have very high frequencies of HBS for, again, reasons, for reasons of antiquity and so on, and the fact that we've all evolved from Africa, and many of these tribal populations actually carried the African, from Africa, the HBS allele and came into India. So it's not easy to be able to differentiate the tribals from the remaining populations just by looking at certain certain specific points on our genome, because they really don't have any specific markers in the genome.
Okay,
I'll
sir,
stop
sir,
here and come
just-
back and answer other questions.
Just stay for a few seconds. Another
Okay.
question which is
Okay.
there, because you have just initiated this aspect, that is how the genetic markers are there and how they are different. But again, another problem which is there, or another thing which has been expressed, is sometimes the tribal people have some protection against certain diseases. So do they have some genetic makeup or in the isolations which make them more protective to the certain disease like diabetes or infectious agents?
Absolutely. So the point is that while they have high prevalence or high incidence of certain diseases, they also have been found to be protective against certain other diseases that most of us won't be protected against. Again, this goes back to genes. So like I said, that there are now genes that we know are involved in various kinds of diseases, including diabetes that has been talked about. But many of these complex diseases, while sickle cell disease is a single gene disorder, diseases like diabetes involve multiple genes, multiple variants in these genes, etc. And these genetic variants don't act in isolation. They also work in tandem with the environment. So it's a complex disorder in the sense that there is an interaction between the genes and the environment. And of course, whether or not you have a very high prevalence or incidence of a particular disease, a complex disease like diabetes, will depend on the frequencies of the variants that combine in order to precipitate this particular disease. And also, oftentimes it's been seen that even if you have that specific combination that makes you susceptible to a complex disease, you may actually not precipitate that disease until the environment is appropriate for expression of those genes or expression of those genetic variants. So it's a combination of both genetic and environmental factors, and many of these tribal populations in places where they live, the kind of diet that they consume probably does not present itself in terms of their ability to precipitate this disease, which actually is protective for them. So this genetic and environmental factors is the major reason why you find differences in susceptibility to various diseases among a set of populations.
So you have again given questions for another aspect of health, that is the adaptation. So does these genes lead to the adaptation, or we are going to discuss more about in certain ways about the sickle cell disease also, how the sickle cell disease having a varied manifestation and how the screening program is helping. But how these genetic markers, if they are same, will they alter the populations if they migrate to another situation or another place, whether they are going to manifest or they have some difficulty in adaptation to that situation also?
So again, adaptation is a very long-term phenomenon. It's an evolutionary phenomenon and doesn't happen in the short term. It happens in a very long term. However, when a population living in a particular habitat migrates to another habitat, oftentimes we see that they were protected against, or they had a low prevalence of a particular disease. Suddenly that same disease manifests itself in larger numbers when they migrate to another habitat. Oftentimes this happens because habitat change leads to physical environmental change, leads to dietary change and all of this. And as I just mentioned, many of the complex diseases are because of an interaction between the genetic endowment of these individuals and its interaction with the environment. So when they move from one place to another, it's not their genes would not have changed, but because they may have moved to another environment which is congenial for the manifestation of the combination of genes, then the prevalence of that particular disease will increase. So I would say that it's mostly with these movements, the population movements, and its relationship with incidence of various kinds of diseases is primarily because of environmental factors and not because of changes in genes, because genes don't change in a short period of time.
Okay, sir. Thank you for your very well said about this aspect of the genetic makeup. Again, the next thing is about the tribal health is the sickle cell disease. And for this, we are going to listen from another one of the panelists, esteemed panelists, and Dr. Aarti will pose questions for that.
This is for Colonel Uday. You have worked extensively with Kanitkar Madam and through AFMC on a very well planned out project in the Nandurbar district among the sickle cell anemia population over there. You have are in the process of having it published as well. But based on that experience and your expertise in that field, I would like to ask you the first question over here is that it is quite prevalent, sickle cell anemia, among the tribal population. And when you studied in that particular area, what were the genetic and environmental factors contributing to this burden in that particular belt of Nandurbar, which is not of the Nasik region? Over to you, please.
Ma'am, because most of the questions that you are going to pose are interrelated, I would request you to finish off all the three questions. I'll answer them together.
Sorry, all three questions.
Yeah,
okay. So first part is about your experience as far as the environmental factors and genetic factors. The second one is the role of endogamous tribal groups. How can we design region-specific screening and management programs for these people? Because they are usually not accessible, or once we do a screening project, it doesn't sustain. At some stage, it is stopped, maybe funding, etc., all those matters. And like, how does inbreeding impact the severity and expression of sickle cell disease in different tribal groups? So I will hand it over to you to look into these three aspects and then talk about your projects as well, sir.
Thank you, ma'am. Thanks for your queries and well-planned session. Can I have the slides, please? So firstly, I'd like to thank MEHS, particularly my mentor, Ma'am Kanitkar. So this is how it all started. So March 2023, Ma'am created a group, sickle cell expert group at Nasik. We were all called together to brainstorm, which included administrators, Ayush, pediatricians, and epidemiologists. Gaps were identified. So whenever we talk anything in the country, we talk of gap analysis, and ma'am did a gap analysis, and based on this gap analysis, we came up with short-term, mid-term, and long-term answers, which ma'am had then conceived. So with permission from MEHS and under the ambit of MEHS, we first took up a pilot project, which was this, which we did it in Shahada, which is part of Nandurbar district, and we worked on endocrine dysfunctions, renal disorders, cognitive dysfunction, and reticular problems, and nail fold capillaroscopy. And after this, we identified that there are some small issues. So based on this, with the help of the ma'am, the AFMC collaborated with the district administration Nandurbar. And we had rounds of discussion. And following this, a project, which was sickle cell care or care for sickle, was started by Armed Forces Medical College. And I'm here not as Kanluday today, but as a representative of my alma mater to say what we have done here. So the first most important thing was to establish local infrastructure and improve it. So we created labs, we created hospital there, and we got a total new construction which was done in to improve the infrastructure in that particular area. So equipment which was flown in from France worth 7 crore rupees was placed in Nandurbar district, and it was inaugurated. Post inauguration, with the help of the various tribal minister and the Palak Mantri, we started off with the project. And the project was done under 3 phases: high-risk screening, mass screening, and multiphasic screening. For the high-risk screening, the target population were identified, which were 3 populations. For schools, 646 schools covering 130,483 students was done. Second, 2,436 pregnant ladies. After we finished the project, there was not even a single pregnant lady left in the district who was not screened. 196 private clinics and hospitals were included. The length and breadth of the Nandurbar was covered. And these are the photographs just to show how the project was done. And thereafter, we realized that we are still only collecting a sample of it. We need to go further. So we went ahead with the mass screening. And 284 villages or hamlets were covered, 19,000 people, door-to-door screening. And they don't have Google Maps there. We drew by hand the various areas. There were no house numbers, such that we do mop-up rounds. House numbers were given to each and every house, every thatch in that particular area. They were all geotagged. And the difficult most areas, which are Narmada backwaters, which do not have roads, we went on boats in those areas. And for 9 months, 200 people from AFMC of different categories, we stayed there day in and day out to finish the project. The last census had a coverage of 72%, whereas we had a coverage of 96%, because every area was targeted with 4 mop-up rounds to ensure that maximum coverage was done. The last part was the multiphasic screening. For all those who were positive, we took their families, because that's important to understand about inbreeding, about mathematical calculations, and how to plan for future screening programs. No GATS, so we used to make tables and draw maps in the night, sit down and say which team will go where and how they will go pursue from one area to another area. Thanks to the local medical college, nursing college, physiotherapy, as somebody was saying in the morning, 200 people every day morning used to be dispatched to work till night 11 o'clock. And total of 1 crore 99 man hours were put in around 100 days with 56 teams, with 1 ASHA worker, 1 postgraduate, 1 undergraduate, and 1 BPMT staff as a team together. And these teams used to go from area to area. Then we realized that there is no Aadhaar registration or ABHA registration. We said, let's take it on. We took it on ourselves. And we first did Aadhaar registrations to all these people, such that tomorrow the data can be merged with the ABHA. Sample collections were done in camps and also wherever we found a person. This next photograph is my favorite. One of the cobbler, he was not ready to leave the job and come and give a sample. So my nursing officers, they went, sat next to the cobbler and get blood samples. So that was the outreach that we would try to do it. Now coming to the sample segregations, every day around 8,000 samples used to come in. We had to divide them geographically and as far as the latitude and the longitude. And then they were all processed and reported on the same day. And finally, having so much of data, every patient would have 210 columns because the demographic data, the clinical data, everything flowing in. We created an application. This was done by Armed Forces Medical Services, wherein we have an application wherein every patient's information, top to bottom, would be on that particular application. And then thereafter, an administrator or an IAS officer can see what is happening with each part of it. Now coming to the quick results. So out of 3,46,000 who were screened, 1,61,000 agreed to get tested fresh. Newly diagnosed sickle cell disease, 0.868%. Previously positive, 1.72. Compound heterozygosity, 0.16%. But trait, 15.23%. And other globinopathies, 5.27. Now, the other globinopathies is something which is very important for us, because most of you who are only doing sickle testing, you would miss upon compound heterozygosity, you would miss upon other globinopathies. It does not stop there. We have to continue with health education. So our nursing officers, they went area to area, to the places, to the houses, and they tried to educate each and every place there. All those who were positive, they were given separate counseling sessions. At the end of it, everybody would say, yeah, we are apolitical, we are in uniform. What is our benefit? We are not here to show what our institute is better than other or not. We are just to say that as a country, we need to allow the population of this country to have confidence in central institutes. At the end of it, when we were leaving that particular place, everybody would say, sir, I'm a doctor banna hai, I'm a fauji banna hai. So that is our gain that we could get out of this particular area. And why was this possible? Because of 5 commandments, which ma'am has told us. Ma'am took a talk around 6 years back about looking into the crystal ball and move out of your comfort zone. Everybody is comfortable sitting in their offices. As an army officer, we have no business to go to this tribal area. It's not part of our ambit. It's not part of our curriculum. But move out of your combat zone. Never undermine someone's efforts. We all get overwhelmed in the last 2 days. ये लोग इतना कर रहे हैं, हम कुछ नहीं कर रहे हैं. But that should be a positive feedback rather than a negative feedback. Acknowledge good work, not snub each other. Encourage whoever is willing to participate and collaborate to increase the output. So this is how we could do that. And thanks to the visionary ma'am, the project which ma'am started and handheld us has led to this, wherein we are continuing the project and have not left it. We have had a population scientist, we have had 2 data entry operators, and every month for 2 days, 2 postgraduates go there. 18 theses are being done at Nandurbar. So it helps a PG to get connected. Again, madam's idea. Now quickly coming to the second question, how to do future screenings. So these are the heat maps that we have created. And if you see this beautiful heat map, you'll find that there is a red zone, gradually blue zone, and green zones. As far as the society is concerned, these are the numbers that they are bothered about. We are not bothered about how many deceased patients are there, because we are not only at treating, we are also at preventing. And for prevention, the 23.24% number is what is important for me. So this is the overall globinopathy burden. And when they get intermarried, there will be an issue. Mathematical modeling. Tomorrow onwards, I would not say everybody should go and screen everybody right, left, and center. It's not possible. It's not feasible. It's not practical, not financially effective. We should take a sample. So for every sickle cell disease who is positive, mathematically we calculated 2.84 will be more positive. And the future designs should be the way ma'am was telling in the morning, 8,000, 10,000 people. That's the ideal way. Do door-to-door extensive screening. Do family screenings. And then thereafter, put a predictive model about how many will be positive in the whole area when we extrapolate this particular information. And for the mass screening in the future, we are coming up, thanks to again madam's encouragement, less than a $1 test, which is in the patenting phase. We have just got it validated, the results validated at Mayo Clinic in December 2024, and we will do that. And we have two other people who are working on it, one on PCR and one on viscosity methods from IIT Bombay and CCMB Bank, Hyderabad, who are doing it. Coming to the inbreeding part of it, the sickle cell that we find is a mild phenotype that we generally see. And why mild phenotype? High HbF percentage that we find in our people. And the alpha thal traits are 11.23% in the society, which are protective in nature. Now, when somebody say inbreeding is bad, I have a contrary view, which most of the tribals believe. We have seen if a Gavit gets married to another person from another tribe, they generally have a severe disease. So sometimes a marriage within or inbreeding can help in retaining the protective genetic mechanisms. But it's just a hypothesis that needs to be worked up by very, very eminent and senior people like this, wherein we understand one tribe with another tribe, tribe within tribe, when they get married, how do they progress? So this is all that I have to say. Thanks a lot, ma'am, and thanks for giving the permission.
Thank you, Colonel Uday. I think so we all should give a hand to Madhuri Kanitkar, ma'am. Thank you. Okay, so I think I will fail in my duty here to take two names on this platform. One is former Vice Chancellor of MUHS, Dr. Mridula Phadke Madam, and Padma Shri, Dr. Sudham Sate, Kate sir, who is very well known to Dr. Pat sir. They are the ones who into Pune, BJ Medical College, and from there it was Dr. Kate and she who went to this area way back in 1980s, Dhadgaon. It is still continued and carried forward by AFMC and BJ Medical College. So we owe it to them as well. And then we move on to the session about potential of Ayur genomics for tribal health. So I call upon Dr. Kuldeep to take over from here. And our next panelist will be Dr. Mitali Mukherjee.
Thank you. I think we are now moving to the very exciting part of this panel discussion. And there are many questions have been arising in the minds of the people, audience also. And one area is that we have not heard of that Ayurvedic can also be helpful in the genes for genetic therapy. How the Ayur genomics can be combined together and provide the health. That is the one aspect we are going to discuss. And Dr. Mitali Mukherjee is expert in this area. She has developed a very well-proofed model and also a Ayurtech Center of Excellence at IIT Jodhpur. So she will be telling about something about how the principles of Ayurgenomics can be applied to better understand the disease predisposition in the tribal population. Dr. Mitali. Okay, all the three questions I will ask. So first question is about the application of to better understand the disease. Second is how we account for the unique genetic and environmental interaction in the isolated tribal groups. And my third question will be, can the Prakriti, that is Prakriti is also part of the Ayurveda study, and how this framework can help explain why a certain tribal population seem to be more resilient or vulnerable to the specific disease. So Dr. Mitali.
Thank you. So, everybody, and thank you, Dr. Madhuri Kanitkar, for giving me a chance to come and talk here. So I'll briefly put the whole thing in three parts: why, so what, and who cares. So why Ayurveda and genomics together? And if we do it, so what? Do we get some new things out of it? And who would be the beneficiary? So here, in the context of tribal population, I'll just briefly tell about it. So basically, Ayurgenomics is just an operational framework which we developed over the last 2.5 decades, and it
connects the principles of Ayurveda with modern medicine. So why we went into it is because as we went into genomics, the idea was how we can personalize a person's therapy, how we can understand individuality, how we can manage the quality of life of a person who is suffering from rare disease or common diseases. We do not have those answers as yet from modern medicine. And 3,000 years back, there was a system of medicine of Ayurveda which has been, meaning it's documented, so the science would have been older, and it's still contemporary. The fact that people are using it, the science must be robust. So we developed this genomics framework to explore the principles of individuality in Ayurveda and try to see whether this actually gives more meaning. So we made a lot of discoveries on the way, and one such example is that like classifying people on the basis of Ayurveda constitution types, which are invariant in an individual and predict their health and disease trajectories, we could actually predict who are the individuals who are living at sea level, could be differentially responsive to hypoxia stress or high altitude adaptation. So from there on, a journey started that here is a method which allows you to classify people such that you are able to predict who are likely to have what kind of health trajectories. And that's where we thought that it would be very interesting to integrate it in modern studies. For example, I'll take the example of sickle cell anemia. The mutation per se is not the difficult part. The more challenging part is how to manage the outcomes of the disease, which could be bleeding, which could be pain, which could be thrombosis, and in the presence of triggering environment like hypoxia, infection, or dehydration. In Ayurveda, dehydrating conditions actually impact a particular constitution type like Vata, and they mostly have pain. And infection can provoke inflammation, which could impact Pitta, more aggravate Pitta in a system, and could actually precipitate into a bleeding outcome. And a situation of hypoxia could provoke cough and could actually contribute to thrombotic outcome. So this is the framework which we have found that different Prakriti individuals have different responsiveness to environment, and they have different susceptibility to particular diseases. So the question is, could we actually go to the field, classify people, sickle cell patient on the basis of Prakriti type, and see whether we are able to find that such kind of mapping, if it exists, could we then identify endophenotypes of the diseases? And if we are able to do that, then could Ayurveda doctors also integrate their treatment regime for customizing treatment solutions? So that's the framework which I'm excited about, and I've been talking to Dr. Madhuri Kanitkar whether we can actually in an interdisciplinary framework work. The second, the most important thing is once you have assessed the Prakriti of a person, it is also the Ayurveda doctors can assess the Prakriti in a context of spatio-temporal dimension. So in a different ethnic background or in the backdrop of an ethnic background or a backdrop of a geography or an age of a person, they are able to still predict Prakriti, which is like a scale-free measure. So once you have been able to assign a Prakriti, then pretty much many of the other kinds of things can be mapped. So the idea is that if people are transitioning today to a particular geography or a particular environment, then Ayurveda has a description about how the geography is likely to impact different Prakriti types in a different manner. So that if people are transitioning, the concept of Prakriti would still hold. So once you've assigned a Prakriti, maybe you would be able to map out the proper developmental, meaning management plan. And it's also non-invasive, and it's meaning the method is based on questionnaire, which can be now digitized and connected in various different manners. So it will become more accessible and more cost effective, and large number of people can be screened. So I think in the given interest of time, I would stop now. But
Dr. Mitali, one question is that what you are saying that environment can also influence the genes. That is
Yes.
how the Prakriti,
Yes.
the personality and this can
So
affect.
Ayurveda has this concept called Desh Anupatini. For example, a dry, like a Thar desert, where I'm staying around there, it provokes Vat in people because the environment is dry and arid. So if individuals are of a particular Prakriti type, for example, you are a Vat Prakriti type, it will get exacerbated towards that axis. Now, the diseases are also described by these perturbations itself. So, certain kinds of diseases would be more chances of getting into that disease state will be more for them. But if people are habituated to that environment, then they will be adapted around that axis. So, it matters to understand what is the baseline kind of phenotype of the population, and on the baseline phenotype of the population you have to then look at how you are deviated from the baseline. So it might be different for different people. So not only it describes the individuality of a person, it also contextualizes the individuality in the context of a population or or a or a climatic background.
Okay, I think that is very important because that is what we are looking forward. That is the climatic change environment. That is we are talking about the concept of one health. That is how the human health, animal health, and environment can be integrated, and also how it can be used for therapeutic purpose.
So I can add just one more thing because I'm a geneticist, not an Ayurveda person. I've often been told that climate change is now. So how would Ayurveda, which is 5,000 years old, can predict today's climate change? But Ayurveda has very interesting description about geography and climate, not contextualized by today, but they will say what are the rock structures, what are the water bodies, what are the human forms, what are the kind of birds. You have to see all of them in totality to describe a geography. So today, if climate change is happening and we are suddenly seeing all the people are getting into one kind of a zone, we might need to redefine those individuality and work back because everybody will not be diseased. Most of our biological systems will be trying to calibrate ourselves. So that's what I think it's work in progress. I really don't know where we'll land up.
Definitely, this is a one new aspect that we are not aware, and I think this is also related to the next question with the panelists and Dr. Bharti.
Make a comment here. I really would like to make a comment here because there are many medical students who are sitting here. And Dr. Singh made a statement, so can environment change genes? Environment cannot change genes. Let's face it. I mean, genes are a specific nucleotide sequence that will not get changed by the environment. Sometimes you have mutations because of impact of the environment, but that's a rare commodity. What is being talked about is that these genes, they express, and the expression levels of these genes will determine the disease. The expression levels of these genes can be modulated by the environment. So we need to be very clear that it's the expression levels of these genes that are modulated by the environment, not the genes themselves. I needed to clarify that. Thank you.
So we move on to our next panelist, and that is the aspect of the advances in gene therapy, genetic diagnostics, and of course, how can we forget about artificial intelligence and its role in genetics? But is it applicable to our resource-limited settings and especially the tribal areas whom we are talking about? Can these new therapies reach these population and make a difference in their life? So we go over to Dr. Chakrabarti. You want me to tell you all the three questions which are there? We have stuck to three questions because of the time limit. So first one is that how feasible is genome editing therapy for addressing genetic disorders in tribal population, considering the high costs which are there? The second is, does the genetic homogeneity of tribal population make them a good candidate for targeted gene therapy, or does it pose additional challenge reaching out to them in those remote areas? What are the regulatory and ethical considerations when applying the CRISPR-based technologies to the tribal health? We have seen they have issues, and your interest in the advances, how can we take it to their doorsteps? Over to you.
So, thank you. And, uh, thank you everyone for inviting me and asking me to be a part of this very distinguished panel. They are really very, very senior teachers almost here who are sitting here. So I'll just give you a perspective of, what gene editing entails. And, it's really, the question is that, is it possible to do, really make changes in genes? I think Dr. Majumdar just said that environment cannot change genes, gene editing can change genes. So it's definitely possible to, and there are people who are walking, living around somewhere in the world whose genes have been altered in terms of the sequence. We are really talking about the genetic sequence. I can come from the context of sickle cell anemia because that's the disease that is widespread in the tribal population of India, and it's a monogenic disorder. It's one of the first diseases that have been, let's say, if we can put it technically corrected, where the mutation that causes the disease have been corrected in human beings. And just last year, the first product, cell and gene therapy product, which basically corrects this, has been FDA approved. And we'll hear about that in the next talk by one of the distinguished speakers who is attending this conference. For the sake of the audience here, I'll just explain a little bit about what, how this works. So, it was for a long period of time, it was kind of considered that as we are a product of our genes, and this is correcting anything in the DNA is kind of a holy grail, because that would really allow us to make changes that could correct disorders in the long term. But it required the development of tools, genetic tools, molecular scissors, as we call them in the field, over a period of almost 30, 40 years. And a very, very, a Nobel Prize with a lot of competition going beyond it to really come up with a technology that is so robust that it can it can correct the genetic sequence. So the basis of this whole process of gene correction is a technology called CRISPR-Cas9. It's something which is was identified in bacteria, as most other molecular tools are, and has been harnessed for use in human therapy. And how this process works is that there is a protein which is called a Cas9 protein, which can be selectively asked to go anywhere within the 3.2 billion letters in the human genome, almost anywhere, and to specifically go and make a modification in the DNA such that a genetic mutation can be corrected. So you can imagine that's extremely high risk procedure. If you can imagine, think about the other places that it can go to, but also to develop a therapy based on this basic principles of finding a DNA target and correcting it is not as simple as it sounds, because it has to be done in cells, in humans, where this change can be propagated and therefore can actually cure a disease. In the case of sickle cell anemia, the technology that has been approved has been to elevate fetal hemoglobin through genetic correction. And it has been done in stem cells of the blood, hematopoietic stem cells of the blood, which has been, which has been taken out from the body of a sickle cell patient through a process called apheresis. And then after correction of the stem cells, these cells are returned to the patient, where they home into the bone marrow and graft and start producing levels of fetal hemoglobin. That is the principle of the genetic correction strategy. Now you can also imagine that fetal hemoglobin is kind of an alternate roundabout route of correcting the sickle cell problem, because if you have high levels of fetal hemoglobin, it has been known for many, many years that it's a condition called hereditary persistence of fetal hemoglobin, and such patients who have HPFH, as they call it, are typically not having the symptoms of severe anemia and sickle cell anemia, for example. So that's a roundabout route, but then sickle cell anemia is caused by a point mutation. It's a amino acid change which causes the protein to become sickle. So there is an alternate route where you could potentially correct the gene sequence which causes this. And this is something where we have been working in India for some time now, almost 7-8 years. I come from a CSIR institute in New Delhi, where me and my colleague, Dr. Shobhik, we have been developing these technologies, or trying to develop technologies which can do this correction very, very precisely. I told you about the 3.2 billion letters, separate letters, where this Cas protein can potentially go and hit the genome and cause havoc. Our focus for the large part of our initial research was to make a Cas protein so specific that it only goes where it is told it's supposed to go. And once we got that, we were able to actually advance it to correct the sickle cell mutation in patient cells. But to convert that into a therapy is a different ballgame altogether, because that means that you have to do this in real patients. And as we all know, sickle cell is something which is extremely prevalent in the tribal population. Now, if there is a drug product, and if you're aware of the drug product pricings for cell and gene therapy, these typically, and that's also one of the questions that was there, these are very, very expensive. In fact, one of the first sickle cell gene therapy product that has been approved costs somewhere between 2 to 3 million US dollars. Correct? And if we convert that, that would be close to 20 crores for a single shot for a patient. And that's obviously not going to be accessible to anybody except where there is, in a very rich country, there is an insurance coverage. So how can one, let's say, overcome that challenge? Because for drug manufacturers or companies, pharma companies, it's not a very lucrative thing to really have a kind of a therapy for tribals, or let's say someone who will not be able to pay that kind of money. So they would rather go for other diseases. I think this is where, in a kind of remarkable vision, I would say, the government of India actually kind of decided to come ahead and support gene therapy or gene editing therapy in India. This happened somewhere around 2019, 2020, when through the Ministry of Tribal Affairs, they launched a kind of a mission to eliminate sickle cell anemia, the possibility of eliminating sickle cell anemia disease through gene therapy. And they said that, we are going to fund you for a phase 1 clinical trial. And of course, this phase 1 clinical trial would involve clinical partners to do the phase 1 trial. So AIMS New Delhi was chosen as the trial partner, along with a lot of other people, clinical, non-clinical partners. And CSR IJIB was designated to not only develop the technology to the point where it can be going into a trial, but also to develop the infrastructure where the cell and gene therapy product can be produced. Now, this is a living drug, so the patient's own cells are genetically modified and then goes back to the patient, which means that it has to be done under extremely pure, uncontaminated conditions, which we, in the clinical term, it's called good manufacturing practice lab. So such a lab has been set up in IGIB, and it's a long process. We are going through different hurdles, 1 step forward, 2 steps back, because we are doing this the first time in India. But there have been people who have done it abroad who are also mentoring and helping us. One of them you'll hear in the next talk as well. But again, to tell you that it is not a cakewalk to make such kind of therapies. It takes time, and it also takes a lot of effort in terms of funding, infrastructure, regulatory, and other aspects, which we have been, I have to say, we have been very, very fortunate to receive throughout this last 4-5 years. The other question was the regulatory and ethical considerations. I think the regulatory considerations of CRISPR are pretty much common across all countries. Several of you have heard about the Chinese scientist He Jiankui, who tried to do editing in the embryo and was called upon, and then proceedings were started against that. So there happens to be a moratorium on embryonic genome editing. That's one of the major ethical considerations. That it's currently, this is not allowed because you are subjecting, number one, it's not a completely proven technology, so you do not know the long-term effects of CRISPR. So that's another consideration, that we are already looking at the first patients who have been treated maybe for 6 months, 2 years, 3 years, But we do not know, for example, what will happen to such patients in the long term. So that is a part of any kind of drug approval and safety profile. The other important consideration is the diversity on who can receive such kind of therapies, and we have talked about that as well, that if it is for the tribals, how does one reimburse the costs? And that is where a lot of discussion is needed with the industry, because the industry has to come in and scale it up. It is not an academic way to do, but also with the government on how the government comes in and tries to make these affordable and accessible to these kind of indigenous populations of the country. I'll stop there, and maybe if there are more questions later on.
I just want to make one single sentence after Debojyoti spoke, which is that this government, and we should be very proud that they have, this government has initiated a national sickle cell elimination program, and by 2047, the government of India hopes to be able to eliminate sickle cell disease. And to that goal, the government of India has initiated multiple projects, such as the one that Debojyoti is doing, and there are multiple projects that are being done in collaboration with other nations to bring these technologies in, and we really sincerely hope that the government will succeed with people like Debojyoti, who are really aspiring to bring these kinds of these kinds of therapies, such that people of India can actually benefit. Thank you very much.
Thank you, sir. No panel discussion can be complete without participation of the audience. So the organizers have given us time, 3 minutes, they said. So if we can have any questions, because it's very difficult to get such senior panelists, take the opportunity. If you have any questions where they could answer, and then we have a wrap up from each one of you as a take home message, please. Any questions from the audience? Yes, sir. Yeah. Can we have the mic here, please?
Myself, Dr. Purushottam Madavi. Sir, question is, I already told that there is no genetic changes in the tribal population. But we know that because the tribal populations or indigenous populations from South Africa or Indians are different. So if there is no difference in the genetics, why the impacts of sickle cell disease, respiratory disease, or tuberculosis disease are different in the indigenous peoples of South Africa and India?
Sir, if you could take it.
So the sickle cell mutation is a single mutation. It changes one amino acid called glutamic acid to valine in the beta chain. The hemoglobin molecule is a tetramer, 2 alpha chains, 2 beta chains. The alpha chains are coded by one gene, the beta chains are coded by another gene. In the beta chain, there is a mutation that changes in the 141 amino acids that there are in the beta chain. At the 6th position, it changes glutamic acid to valine. That's consistent across the world. Any individual with sickle cell disease will have this mutation. Now, why do they manifest? Severity manifestation is different. The reason being that this is not the only mutation or only variant that determines the severity. There are adjacent other mutations, and that combination is called the haplotype, and it's a combination haplotype that actually determines the severity. So the mutation is there, but in combination, different places we have different. I mentioned about Benin haplotype, I mentioned about the Arab India haplotype. The combinations are different in the Benin haplotype and the Arab India haplotype. And it's this combination that actually determines the serious severity of the disease, the manifestation of the disease. But whether or not you'll have sickle cell disease is dependent on that one single mutation. Thank you.
Thank you. Thank you, sir.
One question that we make, because this is a first international symposium in the Maharashtra, all over the India. 15 countries people are taking place in the, so thankful to Dr. Chaudhary sir. But recently there is a genome therapy adoption, because we not of the lecturers that we are supposed to reach to unreached peoples, but how far the tribal peoples are away from the genome adoption therapy, because considering the situations of the tribals, are they are living in the hard area economically, and adoption to the this genome therapy, please.
Dr. Chakrabarti.
Yeah, I think that's the most difficult question to answer. Just let's put it this way that, the first genome editing therapy work in, where CRISPR essentially started off in the US, if you can think about the best labs in the world, it was in 2015-16, and it took them almost 8-9 years to get a product approved. And now there are more complications about how to make it accessible. We are later in the game, but the hope is that with the lessons that they have learned and adopting some of the corrective measures ourselves, we can push it a little bit faster. But as with any new technology, it's almost impossible to predict when it will come. But as you see that, several of us are all engaged very, very actively to try to make it happen. And I think we can hope that something might happen very soon. Yeah.
So if we make it in India, I think so over a period of time, yes, we can do it. We have a lot of scientists working on, let us help them in many ways in which we can. Till that time, I think we should concentrate more on neonatal screening, early diagnosis, antenatal screening, reach out to them in their own environments, which AFMC has shown us very well how to do it. So I will just take this opportunity. There is one, oh, sorry. Yes, please, yeah.
My question is to Dr. Mitali, madam. Basically, we are from Ayurveda background and working in Ayurveda colleges. And you did one wonderful presentation for Ayurveda genomics. Whether the data is in the public domain, genomics data, Ayurveda genomics data, you did some work, madam. And second question is that whether any clinical data is available with the software?
So genomics, it's a framework. So what is the data you are asking about?
Clinical data, madam. Because
So we have not done any clinical data,
Yeah.
clinical study as yet. We just probed the fundamental principles of dosha to be able to understand what would dosha mean in a molecular language. Now that we know the molecular language, we have to go to the clinic to test it out. So only one of the studies we did was high altitude adaptation. We took a lead from Ayurveda of a genetic variation.
Yeah, it is
which
already
we could-
mentioned in Ayurveda. madam.
Yeah, so those are those. So whatever is published, all those data are publicly available.
It is available in
Yes,
public domain.
yes, yes. So we've done exome sequencing, so those data is all available.
Thank you.
think ma'am has
Can
a
we
question.
go to
Ma'am
a
has-
one-liner take-home message? One more question? Yes, please.
Ma'am, just a minute, you will get the mic.
Thank you so much. It's just an appeal to MUHS and to DMER to make newborn screening the prototype in all medical colleges. If I'm making any wrong statement, I'm open to correction. As far as I know, it's only
I
under
think Dr.
DHS.
Aarti will answer herself.
Okay, we have a center of excellence in collaboration with MUHS and Government of Maharashtra. And the procurement process of neonatal screening is already on the way in Gene Health Lab. We hope to start with thyroid screening slowly, but steadily we will be increasing. Next is sickle cell and hemoglobinopathies. Already the diagnosis of thalassemia and the antenatal screening, we have reached in BJ Medical College free of cost antenatal screening for the mothers, which is through the CSR activities, and so is the screening. So we will tie up with IGMC or with you in Gondia, and I think if the samples come to us, we will have a SOP laid down for it, and I think we will reach very soon. By the end of this year, we hope to at least add 6 diseases which could be available all across the 28 government medical colleges. So
Thank you
we
so
need your help.
We are
for
there,
that.
ma'am.
Yeah.
With your permission,
Yes.
I'd like to add a few things. Firstly, I think this was an excellent panel and very beautifully conducted. Thank you so much for it. Whereas all the work done, I think I would love to tell people that what Dr. Mujumdar just told us, I think it's a celebration of science that India has reached. We take pride in the fact that, you know, we had a moon landing and we had Mangalyaan. I think it's a matter of pride that we have Devjyoti, who has created this Cas9 protein locally, which is going to bring down costs tremendously. So let us look at a future where, firstly, we'll try to prevent it through people like Aarti and Uday, who will screen and make it. But for that one slip out who has a severe disease born, the child is born, we will have our own technology. You know, HIV was such a dreaded and stigmatized disease till we produced one tablet a day and you can live forever. So I think that is the aim. And nature is helping India. What again Dr. Majumdar said is about this adaptation. I think we've had these epigenetic changes which have occurred. What Uday presented today, that we have a very high level of HbF. So that is why we do not see the severity with which Africa, the variation that you mentioned, I think this is a different haplotype where we are not presenting with such severe manifestations. So, I mean, let's learn from each other, but also provide solutions to each other as to how we can do that. And I'm very happy to also say that gene therapy, that is cell and gene therapy, CGT, is being taken up on a mission mode by the country. Separate funds, separate streamlining, ethical clearances are being the same, and this has been, the decision has been taken just last week. So I think this is something really we all as Indians need to be proud of. Thank you so much.
So one quick wrap up, Colonel Uday, you have a take-home message, one-liner, which will stick in the delegates and they will try to implement it.
No cross-sectional activities, please do longitudinal activities. Vocal for local, please build up empower the locals such that all the bigger institutes should help the local colleges and the local infrastructure to grow. So that's the way forward.
Thank you.
Yeah, I think I can only say for myself and the gene therapy team at IGIB that we have been benefited a lot by people who have taken up leadership roles in this mission in different stages. So that's very, very critical in a diverse country like India, because positions change, priorities change, and it's very difficult for younger people and people way lower in the hierarchy to keep things pushing. So it's an appeal to people who are much more advanced in that level to have that push continuing. Otherwise, these are not drugs that will come in a year. It won't come in 2 years. You really need to have a vision for 5-10 years. Only then success will come. So it's not a short-term thing. It's a long-term thing, and we need sustained effort in that direction.
Would like to see what I began with, which is that we need to be respectful to the tribals and we need to treat them well. We hope that the various kinds of health parameters that they suffer from will actually improve, and especially with respect to sickle cell disease, that's really been the focus of this panel discussion. We hope that by 2047 the disease will be eliminated by the multi-pronged attack that the government of India has undertaken. Thank you very much.
I think we need to harness the natural traditional knowledge with evidence-based approach to be able to provide more personalized health options in an affordable manner. So tribal populations are a rich treasure trove of a huge amount of knowledge which can be now interrogated in the laboratory system. And if you have an evidence-based meaning an evidence that it works on the same pathway which are actionable by other strategies, then you can actually find ways to have the tribals adopt that with a way of science. So it requires a lot a number of people to cross-talk freely, because Ayurveda and modern medicine people have discomfort talking to each other, and I'm trying to develop a conversational language. So I think we need multiple disciplines to crosstalk and to evolve solutions, which is good for us as patient, as stakeholders. We need more options and more evidence-based options. So thank you.
Thank you. Before we wrap up the session, I call over my co-moderator, Dr. Kuldeep, and a message from me is that there are 18 international faculty over here. Through MUHS, we would like to collaborate with you as far as the illnesses in tribal population is concerned. We are open. At BJ Medical College, we have the Center of Excellence. So as far as genetics is concerned, we are always ready to work with you. So that's the take home from me. And I hand over to Dr. Kuldeep to wrap up the session, please.
Thank you, Dr. Aarti. And I thank all the panelists for a very wonderful input into the genetics and how this is helping the tribal health. But I would like to say a final word is that we have to develop the trust. Trust is very important because they have to trust us and we have to trust them. And that we have to preserve their indigenous nature because something is beautiful in there also and we have to learn from that. So cross-learning is also important and trust is very important. So with this, we end this session, panel session. Thank you.
First of all, a huge round of applause to our panelists and to our moderators also.
I thank esteemed panelists and our moderator for this excellent panel discussion. May I now invite Lieutenant General Madhuri Kanetkar, Vice Chancellor MUHS, and Dr. Prashant Joshi, Executive Director, AIMS Nagpur, to felicitate our panelists and our moderators. May I now request our esteemed guest to felicitate Dr. Pata Majumdar. I request our renowned guest to felicitate Colonel Uday Enamanda. May I now request our renowned guest to felicitate Dr. Mitali Mukherjee. May I now request our esteemed guest to felicitate Dr. Debjyoti Chakraborty. May I now request our esteemed guest to felicitate the moderator, Dr. Kuldeep Singh. May I now request our esteemed guest to felicitate the other moderator, Dr. Aarti Kinikar. Thank you all. Thank you all. With this, we are moving towards the last final session of today. To commence the session, I now request Dr. Sandeep Soni, researcher, executive director, CRISPR Therapeutics, all the way from the USA. Looking forward to hear from you, sir.
I request chairpersons for this session, Professor Milind Nikum sir, Pro Vice Chancellor MUHS Nashik, and Dr. Tanuja Nisari, former Director, All India Institute of Ayurveda, New Delhi, to please come on stage. Also, there is an important announcement. Just after this session, we will be moving to the banquet. It's very near to the venue. All are please requested to assemble just outside the auditorium. There are vehicles arranged, and the venue is just 3 kilometers near Ames. It's Gaikwad Patil College, and it's on the Wardha Road. So all are requested to kindly assemble after this session outside the auditorium. All the vehicles are arranged for you for the banquet. Thank you. Very nice.
Going forward. Right. Okay. And the point, you have a point.
Yeah, before starting this session, just I want to conclude with the last session that was related with the Ayur genomics. It is written in Shushruta, Yasya Yasya hi anga avayavasya bije bhaga upatapto bhavati tasya tasya hi anga avayavasya vyadhir upajayate. That has been written here. Bija means male and female gamete. Bija bhaga, that is chromosome, and bija bhaga avayava is called as genes. So whatever that it has been told in the Sushruta that how the genes are involved in the disease formation, that has been just written in that Sushruta. So that I want to just conclude with that session. Thank you.
Well, thank you, everyone. Good afternoon, good evening. I'm Dr. Sandeep Soni, as you heard. I'm coming from CRISPR Therapeutics. I'm actually a pediatrician, hematologist, bone marrow transplant physician, and this is actually very, very rewarding for me to be involved in, as you heard, the Indian program. I'm on a visiting fellowship now from Government of India to come here for next 3 years, for a whole period of 1 month, and help develop this new program you heard about, developing the gene editing therapies for sickle cell patients. I trained in India, as you can see from, I'm Indian. I trained in India from Delhi, I started taking care of thalassemia patients during my career. That was my first involvement with hemoglobinopathies. Obviously, in Delhi that time, I didn't see any sickle cell patients. I never knew there were sickle cell patients in India at that time. Moved to US, I took care of thalassemia patients there, and you may not know, but there are so many Indians, Pakistan patients, so I took care of those patients, and then I started taking care of sickle cell patients. And then I'm a transplant physician. I started my whole mission till now. Actually, you do a great job of doing preventive care, which is very, very important and needed. From me, the mission was definitive treatments. So I've been involved in taking care, doing transplants for thalassemia for last 25 years, sickle cell disease, and for last 10 years, now I have been involved in two projects, two drug product developments for gene therapies. First one was a company called Bluebird Bio, and they made a drug product which is actually a lentiviral base. They add the whole hemoglobin gene into the stem cells, and that was also approved on the same day as a gene editing treatment, which I work for now, the company called CRISPR Therapeutics, which is based on the CRISPR-Cas9 gene editing, which I will talk about a little bit. And now I'm coming back to my roots, doing the same thing and helping in donors. So this is exactly very, very rewarding for me. So I won't go into details of sickle cell, as you all know, you heard. The only thing I will mention in the last few years, everybody thought that sickle cell patients, they come in, they have episodic treatment, they get pain crisis and they go home and you manage them. Even in US, it was a very much like an episodic treatment. What has changed over time is that this is not an episodic disease, it's a chronic inflammatory state, and that leads to continuous organ damage, and that's why there is much reduced life expectancy in these patients. And the goal has changed, that we need to define or find out some curative options. So one thing I wanted to highlight here, I don't like the word curative for sickle cell disease or thalassemia, for example. The reason being, we're not curing their, as you may know, the genetic transmission to the offspring. Only thing we are doing is taking care of their symptoms by doing transplants or gene therapies. So just remember that we are changing their stem cell, the hematopoietic stem cells, by doing transplant or gene therapies. We are not changing in any way the risk of the transmission of the disease to the offspring. So all these prevention programs you heard and wanted to talk about this is still very, very important, even though we will still have these treatments available. So just wanted to be very clear, very off on, this is not curative. This is a definitive treatment for patients. I hope everybody understands that now. And then that's why early intervention, the earlier we do it in pediatric young patients, better will be the outcomes. So Debajyoti already mentioned this, what we use a technology which has led to the Nobel Prize, and we as a company, we are at advantage because we were the first company which took the name CRISPR, because now you can't do that. Because this technology, the platform was the CRISPR-Cas9 platform. And the whole thing it does is, so there are three components to the CRISPR-Cas9. So Cas9 is basically the scissor. Think of it as a scissors, which is go and cut the DNA. That's all it is. It doesn't know if you throw the Cas9 into the nucleus of the cell, it's going to cut wherever it needs to. So you need a guide to direct this Cas9 to cut where it is intended to cut, so that you have precise edits where you want to it. So you design, these are again designed guides, and you attach it to the Cas9, and then the guide takes the Cas9 to the intent where you want to make the cut. So that's why this is a very precise, clean system, that you can now have the ability to make cuts in the DNA wherever you want the cuts to happen. So that's the beauty of this system. Once the cut happens, there are two ways the cuts can be, so you think of this cut is made in the gene. Now, there are two ways you can repair this, because one is what is called non-homologous end joining, or NHEJ. So think of this as a, when you have you tear your clothes or something, and you put the two ends and you stitch. I think in India it's called rafu karna, right? So that's what this is exactly. If you think of it, we are doing. There's a cut, the two ends come, and then there are natural DNA repair enzymes in your body, and they just come and repair the cut. But you leave a little bit of what we call insertion deletions, and you can test for this. So what it does is, since these cuts are made and new sequences are added here, this disrupts the gene function, or the protein production of the protein is stopped. So what you have done is basically this mechanism creates deletions or knockouts the production of the protein. Then because you have knocked out this gene, the protein cannot be made, right? Now, as you know, sickle cell is a single gene mutation. We already talked about E6B mutation. You cannot use this technology because you're not deleting a gene. You want to correct that mutation, right? So the second part is what we call homologous directed repair. That's the second way of correcting with using gene editing technology. And here what you do is, so you make the cut, the CRISPR-Cas9 is going to do the cut the way it is supposed to do. But then you add provide another normal sequence of the gene by short oligonucleotides. You can deliver it by some AAV virus. So you provide the normal sequence of the gene which you want to be inserted into that cut, right? So this is actually a repair or a correction process. So you made the cut, and now you have the right frame of the gene, and it corrects on its own by this recombination process, and now you have corrected it. So what Debajyoti and all the process they're talking about is the actual gene disease or actual mutation correction occurs by the homologous directed repair. But the point is you add another element here, or the third component is needed, which is delivered by oligonucleotides or some other process. So obviously this process is a little bit harder, because imagine it's a coincidence where you have to provide the cut has to happen, then the template has to reach at the site, it has to be inserted. So there is a lot of, it's not a very efficient process. Compared to this one, we make the cut, it's very, very efficient. So to make this happen, that's why I wrote it down, less efficient, high fidelity, insertion-based, double-stranded based repair. But I think my point was, these are two different processes. So going back to the sickle cell, we all know, I will skip this, hemoglobin F is very important. So what we did at CRISPR Therapeutics, we are not doing gene correction. I just wanted to highlight that. I think people are getting confused here. We don't have a technology which Debajyoti has, even in US right now, to do sickle cell gene correction. What we are doing is a different technology using what I told you, the deletion technique, the NHEJ technique, to do gene editing. How we are doing that? It has been discovered that, as you very well know, hemoglobin F is made till certain age, and by the time you are 6 months of age, hemoglobin F disappears, right? And that's why the manifestations of thalassemia, sickle cell come in. So everybody was trying to figure out what is the genetic process which stops the production of hemoglobin F. Why does it stop after birth immediately? So then they discovered that there are 3 or 4 transcription factors which stop or break which work on the hemoglobin, the beta globin gene, and stop the production of hemoglobin F. And one of the transcription factors, which is actually located on chromosome 2, is called BCL11A. This is another gene located on chromosome 2, different from beta globin gene. But this makes the BCL11A protein, and so think of this, I call BCL11A your brake for hemoglobin F, is putting the brake. So simple idea for us was, go to chromosome 2, BCL11A gene, delete the sequence of the BCL11G, stop the production of BCL11A, and it will reactivate hemoglobin F. Nobody had done it before. We had to show that it increases hemoglobin F. So that's the technique we used, did all the work, showed that it leads to, so once you stop, this brake is gone, it reactivates production of hemoglobin F, and the stem cells then, which are corrected with this gene editing process, start making hemoglobin F. So just to highlight, this technique is very different from what we're trying to do in India, because that's a gene correction technique. And to me, it is very important because I'm here now helping you guys, because there's no conflict. So it makes my life easier. So that's the gene editing part. Now comes, how do you deliver this treatment? And this is the hard part also. And you will be hearing all these questions about how it will happen, what will happen. I can tell you, this is like a transplant again. Although we are not using another donor and you don't run the risk of GVHD, all those things, right? Because these are patients' own cells which are corrected. But it is still a transplant process. We call this an autologous transplant, meaning that you are wiping out the patient's bone marrow still and putting the new edited cells back to them. So the first step is obviously what we call mobilization. You have to give some agents to these patients. For sickle cell patients, the one agent we can use is called Pyrexafor. You have to collect large number of cells from these patients to take them to the lab to do the gene editing or gene correction. This process is same for all the gene therapies, basically. So you collect the stem cells. This is done by Pyrexafor with apheresis. This is like a day procedure. We have to do multiple cycles, maybe. So it's a day procedure, but still the patient has to stay in the it's not a hospitalization. It's basically wash them very closely, make sure they don't get side effects from Pyrexafor. Usually we have to do maybe 3-4, each cycle, maybe 3 days. So we sometimes have to do 3 cycles to collect enough cells. So you can imagine 9 times patient has to go through this maximum. If some patients we don't know yet, some are very good mobilizers, so you mobilize very quickly, and some are very slow, so it takes multiplied. So it varies from patient to patient. And we are doing some kind of genetic understanding also now to figure out who will be, or predict who will be a good mobilizer and a bad mobilizer, so we can plan things accordingly. But it's a tedious process, collection itself. Then the cells are taken to the lab. We select the stem cells, do the manufacturing, the whole gene manipulation happens. This takes around 2 months process. The correction or whatever you're doing is 3 days. But to ensure that these are good quality cells, you have to do a lot of testing on it before you say these are good enough cells to be put back into the patient. And that testing actually is very, very rigorous because you're doing the manipulation, gene manipulation and putting it back. You have to ensure the quality of the cells is really, really good. So there are a lot of tests, and some of these tests may take around 6 weeks turnaround time. It takes 6 weeks to get the results. Only then the product is released. So patient can be at home this time doing, we're not treating them. Once we have qualified the product for infusion, that means it is good to infusion. Then it goes to the hospital where it's going to be treated. Then the patients get admitted. They get busulfan, only one drug for wiping out. This is not like transplant where you get a lot of drugs. This is just one chemotherapy drug. That's it. It wipes out the patient's own bone marrow. But the point, remember, once you wipe out the bone marrow, then they don't have any white cells, red cells, platelets. So they are on infusions. You infuse the new cells, gene-edited cells, and it takes around 3 to 4 weeks for the new cells to regenerate and start making the white cells and all. The patients are in hospital during that time. So average stay in the hospital is around 4 weeks. And then once they are recovered, they are out, we do follow up on these patients and then long-term follow-up to make sure everything, safety and durability is maintained. Whatever you've done the editing, you keep on seeing the same results in these patients. Okay. So I don't want to go into deep, so I just want to show the results of the first studies we did with our technology, with using the CRISPR gene editing, trying to increase the hemoglobin F. So this is just our trial. Patients were 12 to 35 years of age. We have to have a lot of pain crisis to enroll on the trial. We calculated how much crisis they had in the past and enrolled only those patients. Patients 12 to 18 years, this is just a breakdown. We had different beta S genotypes, but some of them were also beta 0 included. So again, remember this, because we were trying to increase hemoglobin F, we can include beta 0 genotypes also in our study. They had around 4 episodes average prior to coming into the trial. And majority of these patients are at least around 2.5, because it's averaged out annually prior to being included in the trial. And I'll just walk you just quickly through these curves, which shows the effect of the treatment after the infusion and after treatment. So these is pre-treatment. The gray zone is what it shows. So blue is each crisis, the blue dots. So we collected the patient's data. So this is the pre-treatment time going back to last 2 years. So you can see how many crises these patients are having. And these are not crises, these are hospitalizations. So these patients we knew documented they were getting hospitalized for their sickle cell. And this is the time of the treatment. The red is when they were getting red cell transfusions, because we can only see hemoglobin F once they stop the red cell transfusions. The gray zone after that is 60 days after the last red cell transfusion. And then we want to see the results, what happens after that. And as you can see, the green bars is the post-treatment follow-up. Blues are the crises after treatment. Some of these patients had no crisis. We have follow-up data now going up to 3 years. Patients who got treated earlier were for 3 years. Some of them were at 6 months only. But as you can see, and these crises which happened, actually, we don't know, but majority of these crises happened if somebody got infection. Otherwise, none of these patients were getting. So remember, we had COVID also outbreak. Some of these patients did got COVID, and that somehow precipitated some pain crisis in these patients. And that's why you see some of these patients, getting crisis in spite of the treatment. But otherwise, we had completely VOC-free period for majority of the patients. So technically, this completely made them, again, not curative, but we solved their symptoms and solved them from having problems. And this is their hospitalizations. Again, this is much cleaner. Very few patients had, again, because of COVID or other reasons, they got admitted, but none of the patients got admitted after the treatment. And this is the hemoglobin F percentage. As you can see, all of them had around 45% increase there in their hemoglobin F. Safety-wise, all the complications or safety issues we had, the side effects we had, was related to the busulfan chemotherapy, because that's what causes the side effects and all. There was no reported side effects from the drug product or the product we infused in the patients. So this is our data. Now I'm here to help the project from our Indian project, how to develop this forward. And like I said, the neat thing is I removed the list here because the Devojoti's group has now developed the homologous directed repair process, the correction process, into a much more efficient process. So now our goal is to correct that E66 mutation, do the correction, and then bring it to the clinic. So the only thing I would say is I want to highlight the difference between, so this project again is by CSR IGIV. It's been named as BIRSA project. I think it's biomedical, what is it? Devajyoti may help me. So it's called BIRSA or relief of sickle cell anemia. Biomedical innovation for relief in sickle cell anemia. That's what it stands for. And then the only difference again wanted to highlight the two are different. Here we targeted CRISPR-Cas9. This uses ODN as a separate because you have to have the development cost of an added agent here now to provide the correct template. We didn't need that. This targets the BCL11A. This is actually correcting the E6V sickle cell mutation. We want to see how many stem cells are edited. But now when we release the product, we want to ensure how many percentage of the stem cells, we will never get 100%, but we have to ensure a certain percentage of stem cells are corrected. They have the exact corrected sequence before we infuse that back to the patient. Because if it's a very low correction, even if it is there, it's not going to benefit the patient, right? So we have to have a certain level of correction to go back and infuse it back to the patient. And the idea is to increase hemoglobin F, and here we have to increase in hemoglobin A. One of the impact of this is for when we are planning the clinical protocol, we cannot use anybody who is on chronic transfusions. The reason is because our output is increased hemoglobin A. If they are already getting blood, we cannot monitor that, which we could do in our studies. So we'll have to select patients who are not on chronic transfusions. That's the only kind of factor. But I heard from talking to a lot of sickle cell physicians here that there are not many patients who are on long-term transfusions. So that's the only catch. And yeah, so there are a lot of rate limiting steps. As you know, this is a challenging project. As you heard, there are a lot of challenges. When I started this, before I came here, I put these challenges, and what you see in blue are already being taken care of. So it kind of takes away half of my job. The group here, like you heard, there is a lot of incentive from Government of India. So a lot of these things have already been tackled and taken care of. And now we are focusing on the large-scale manufacturing issue, how to do the large-scale manufacturing, ensuring that we have the right product planned, and then the clinical part of it, the right protocol, right selection of patients. Because again, I've heard this, there is high hemoglobin F Indo-Arab population. So that's the genotype. What we have to select is based on the phenotype. Patients who may have high hemoglobin, doesn't matter. If they are in the hospital getting crisis repeatedly, those are the patients we want to target for this type of treatment. So everybody will not be getting this. If they have mild phenotype, this is not intended for them. This will be for patients what we call severe phenotype. And then we have to decide what that severe phenotype is. Make that as our eligibility criteria and then move forward in our treatment. So I will stop here if there are questions, but I just wanted to give how this has progressed. Two treatments are approved, but the goal is to, again, you heard, they are very costly. I'm a scientist. I don't plan all the commercialization. My goal is to develop these treatments. And hopefully we will have something, a low cost alternative developed indigenously. And maybe we can then help, our friends and African nations to take this forward. That's my goal and that's why I'm here. Thank you.
Thank you, sir, for your impactful presentation. Now I'd like to welcome the next presenter for today, Dr. Jala Wilhelmina, former Health Minister, Republic of Liberia, West Africa, to shed some light on the topic, role of traditional healers in sexually transmitted disease management in Liberia, West Africa.
This is the entire panel was for the traditional medicine healer and its promotion. But I think that the Dr. Soni who presented was the continuation of the previous panel discussion. So maybe at the end, we can also invite some of the questions. Anyone want to have the question answer? Maybe, yes, okay. We can have at the later.
Okay, so I can press there, right? Good afternoon to all. Let me first say a big thank you to the organizing committee, Dr. Tractory, for inviting us all the way from Liberia to come and be part of this all-important event. And let me just thank everyone for the great hospitality that they have been giving us since we arrived here. Thank you so much. My presentation is mostly on what's happening in Liberia in terms of traditional medicine. There's an introduction, a tribal group of Liberia overview of the Liberian traditional medicine product, sexually transmitted disease, traditional medical knowledge, herbal plants, and achievements. The objective is to assess the knowledge and practice of traditional healers in the management of STDs, to document traditional medical knowledge, and to create awareness. A little background on Liberia. Liberia is located on the west coast of Africa. On the north is Guinea, southwest Sierra Leone, my neighbor. To the east is Cote d'Ivoire, and then we have the Atlantic Ocean to the south. Liberia is a very small country from what you can see. It's about 143,000 square miles. The current population of Liberia is 5.4 million people. 60% of that population is under the age of 25. Majority of the people, 52% of them live in rural areas, and 29% of the people live in 29% of that 52% live in rural areas, which is 5 or more kilometers away from the nearest health facility. The population, those populations have little or no health services, or there are community health workers that are in the villages and town, but mostly they rely on other ways of being treated. The vegetation of Liberia, you have tropical rainforests, which cover nearly 45% of the land. You have savanna green land, you have mangrove groves, and you have swamp. We also have the same weather conditions of Sierra Leone. We have the rainy season and the dry season. Now, we have a diverse cultural background where we had the primary languages derived from 3 groups, the Kwa, the Mende, and the Mana. These 3 groups makes up the 15 tribes and the 15 different dialects that are spoken within Liberia. Some of the tribes, we have the Pele people, which are mostly farmers. You have Bassa people, which are mostly fishermen. You have Manon, Kru, Gribble. Each one of these different dialects does a different thing for their livelihood. Like almost all countries, we have a regular tier in the health system. You have the primary health care, you have the secondary health care, and the tertiary health care. But Liberia has suffered 15 years of civil crisis. So can you imagine the whole health system was crumbled, or there was a lot of brain drain because a lot of the doctors, nurses all left the country during that time. So it made us wonder who were taking care of the people while everybody was leaving during the war. This was also followed by the Ebola crisis in 2011, which also left the health system crippled, and most people had nowhere to go for treatment, so they had to rely on some group of people. So this brought us to the platform where we started to wonder, and we decided to call the tribal people to find out how were they cared for during the war, who took care of them during the Ebola crisis. So that set the stage for us calling going back to the tradition and calling all of the traditional people to say, listen, how many of you are there? And then we found out that there were about 7,000 practitioners that was practicing traditional medicine within the country. And we also found out that what were they treating? And they said that they were treating malaria, STIs, they were managing other chronic diseases. And these people range from 18 to about 65. So you had a wide range of people, even more than the number of doctors within Liberia. This is the distribution. We can see that there were 4,580 men and 2,911 female. The highest number were in two of the counties. In Nimba County, we had 1,502, and in Bomi, we had about 200. Now, how do we call these traditional healers? We call them traditional healers, or in some places, they call them the zoos. I know in other countries in Africa, zoo means something else, but we call our people zoos. Now, we wanted to find out, they even had a specialization. So you had the one group were called the herbalists, and these were the people that dealt with medical plants for treating ailments. Then you have bone setters. Those people only took care of broken bones, arthritis, and other musculoskeletal injuries. Then you had the spiritual healers, those who address spiritual or supernatural causes of illness. And then you have faith healers, which use religion and faith-based practice to heal people. In Liberia, and I'm sure in other African countries, nobody died of natural causes. As soon as you die, they say it was some witchcraft or something that killed you. Even though we know the cause, but we still put it on witchcraft. So we know the definition of sexually transmitted disease. We'll not go over that. Now, traditional medicine knowledge of sexually transmitted disease revolves around the indigenous practices and the use of natural remedies passed down through generations, like all of the traditional medicine. These practices typically involve the use of root, herbs, animal parts, spiritual ritual to diagnose, treat, and prevent STIs. So if you go to a traditional healer for some disease, they will find a way to communicate with the spirit, and then sometimes some of the things that they brought up were good, and sometimes they were bad. If you unfortunate, they will tell you your mother is the one that's responsible for your illness, which is not good. It makes you not want to communicate with your mother. So sometimes it was good and sometimes it was not so good. Now, one of the most important places that we can find most of the traditional medicine is under one of the highest mountain in Liberia, which is the Wadogisi Mountain. Under that mountain, you have a big community of 40,000 people with 47 villages, and they were the main one responsible for almost all of the herbs that was shown up and almost all of the different diagnoses that have been made. Now, to get to anywhere, this is the way you have to pass. So this is the way you went just to get to the rural area. So can you imagine trying to get to the rural of rural areas, what you will have to go through to get there. The roads were bad, and I'm sure a lot of people can identify with some of these roads. Now, how were the herbal remedies prepared? Or either they would make it put it in the bath water for people to bathe with it. They made some kind of cream that you will rub on the different area, or they use the leaf, the root, the bar, or they mix it in or some way that would treat the illness. But there was no standardized or treatment, and there's no order to the treatment on how much you should give to treat any particular disease. This is one of the major problems that's going on. Now, these are some of the herbs that were used to treat the different types of STIs, gonorrhea, syphilis, or irregular menstruation, sometimes testicular problem because of of pain or swelling of the testicles. Or these are the tribal names. So based on that, we ask or the herbal center that's in one of the counties to look at the plant, look at the name of the plant, kind of document where they treat and give us the botanical name. So they were able to do that for us. And so that's how come we know the roots and the stem and the whole plant that they use to treat the disease. Now, these are some of the plants. For example, this is the name in red is the name of the plant that the tribal people call it. And then the name of the plant is, the botanical name is at the top. This plant was used to treat STIs, or they will use it out of the bark or make a cream if they need to use it. There's another plant, the tofu. It was also used to treat STIs. You have another plant, we just showed a different plant. It treated genital warts, it treated syphilis and gonorrhea. So this is a very good plant that you can use to make the herbs that you will need. Also, there's another plant. Yeah. There's the plant there, used for gonorrhea. This was also used for gonorrhea and syphilis. There's another plant that was also used, that's the name. And this is another plant and another plant. Every one of us know papaya, but it was also used as one of the herbal plants to treat the sexually transmitted disease. This is another plant here for syphilis and gonorrhea. This was used for liver disease and gonorrhea. So even though they were using that the plants, we also had to look at the incorporating rituals, charms, incantations, in order to treat the STIs, because they believe that the STIs could have been caused by some spiritual imbalance that would have been affecting the people. Now, we also wonder how they were making these diagnoses, because they didn't have any kind of medical tools, but they listened to the individuals telling them what was really happening to them. They looked at the signs and symptoms. If you come to them and you tell them that I have this discharge, or I having this itching, or I having this growth, and that's the way they made their diagnosis. But it also, because of ancestors and culture, they also maybe threw the gamble down and they looked at you and they were able to say, this is what you have and this is the treatment for it. Now, what was done? Before the platform and the stage was set for for us to call them together after the war and after the Ebola, there was a legislature already on the books from 1979, and it was in the public health law, Title 33. Now, we went back to that law, we pulled that law out, and in 2015, right after the Ebola, we were able to carry on the first national traditional medicine policy and strategic plan, because you needed to do something. Now that you have found out all this rich information, you needed to do something. And then it was reviewed in 2023, and now there's another revision that's coming up in 2025. We need to move fast because of climate change. Preservation and conservation is very important. A lot of these things under the Walagisi Mountain, the climate change will cause the weather to either be too dry, too wet, and destroying a lot of these plants. So time is not on our side to be able to save and compile some of these plants that were used. Now, we have been working with the West African Health Organization, which have been sponsoring training programs for all of these herbal practitioners and trying to put together the herbal medicine so that we can incorporate it into regular practice. There was a lot of training going on. This is a picture of a 3-day workshop by the traditional healers in Buchanan. So we are now identifying them and calling them to workshop. This was a 5-day session with the pharmacist student and the traditional healers coming together to be able to talk on toxicology and herbal products so that we can know or what, so we can share knowledge and be able to combine our forces. There was another traditional orthodox medicine practitioner together again. There was another meeting. On one side, you have the pharmacists, and on the other side, you have the traditional healers. More regulations, we need more regulations because we haven't tested any of these products, but we need more regulations. We need help to be able to identify and quantify these medications so that we can be using it in the orthodox facilities, because it will take a long time before the rules are pliable for us to be able to treat those who live in a hard to reach town and villages. But luckily for us, the traditional medicine traditional healers is those. They have a traditional medicine federation of Liberia and the Liberia Zoo Herbalist Union. So this is a great help for them because now they are grouping themselves together to be able to work along with the government. But it's good work for the government because within the Ministry of Health today, there's an office where you have a traditional medicine office where the herbalists can go to. There's the Liberian Health Regulation agency that are licensed some of these traditional medicine individuals. And so the head of the traditional medicine unit within the Ministry of Health is the one that came with me, Dr. Kamara. He's sitting down right in the audience, and he was able to help me to put this presentation together. The challenges: lack of standardization. We have good medicine, but we need to standardize. We need to do quality control. We need to have dosages that will treat whatever diseases, so to avoid toxicity in the individual that will be taking the medication. Insufficient scientific validation or potential interaction with modern medicine. Sometimes you take it and it might cause more harm than good. Or because of the stigmatization of STIs within those of our community, that led individuals to seek traditional. Sometimes you're in the city and you have it and it's not being, you treat it and it's not being cured, then you find yourself using the traditional healers because you think it's witchcraft or something that put it on you. Insufficient funds, we need partners to help us to research all of these herbs. We have more, we only presented on 11, but there are many, many more that I think would be beneficial to medicine outside Liberia as well as in Liberia. In conclusion, traditional medicine in Liberia remains rooted in the indigenous practice despite interventions by the national government and the international organization. Research on Liberian medical plant is still limited, underscore and the need for more extensive study and capacity building initiatives to improve the quality and standardization of traditional healthcare practices cannot be overstated. We'd like to thank again all those who help us come here to present this information, and we hope that we'll be able to produce the plans in a way that can help many more people to treat some of these diseases within the tribal villages around the world. I thank you.
Thank you, ma'am, for such an incredibly informative presentation. Now, I'm glad to welcome Dr. Padma Gurmeet, Director, National Institute of Sowa Rigpa. He will be offering a powerful and eye-opening perspective of the Soga Rigpa system of medicine.
Tuže doi tonza tumdam dat sanzon tsusangan de dungal set tuksumnat sesengam manjil apedur iayi kodla chak salo. Namaskar. I'm starting my presentation with prayer to Medicine Buddha. Actually, from last 2 days, there's very good deliberation going on. Particularly, first of all, Honorable Chairperson of the sessions, Professor Nikum and Professor Tanuja Nesriji, and distinguished participants, ladies and gentlemen. Namaskar, good evening. So actually, I'm going to talk about Sowa Rigpa system of medicine. Actually, Sowa Rigpa is a classical example that how a tribal, earlier known as a tribal medical tradition, got into the mainstream Ayush system of medicine and incorporated into national health policy. That is a classic example. And the Sowa Rigpa case will be very useful for many other traditional medical tradition to get into mainstream, particularly tribal medicine. There's not much powerful policy from government side. We did try to advocate for traditional folk tradition during the 11th and 12th Planning Commission meeting. I remember that time we had a particular Ayush steering committee, and through that committee, we have also put forward many policies. There was particular session called revitalization of local health tradition. But luckily, now the status of Sowa Rigpa is changed from a tribal traditional medical tradition to mainstream Ayush medical tradition. So my paper title is Sowa Rigpa System of Medicine, the Backbone of Public Health for Communities of Ladakh. Actually, this was wonderful gathering of all the experts who have been dealing with tribal health, but it would have much better if we had some representation from tribal communities of India, particularly since it is happening in Nagpur. Nagpur region is quite strong with traditional healers and all these things. We should have also invited some of their views that how they want to revalidate and strengthen their own practice. Because most of the time, policies done by people sitting in Delhi or in powerful positions, and many times they don't take feedback from the local community. So that is one big challenge. We have observed in Ladakh now, until recent time, Sowa Rigpa was not incorporated into main health system, but it was the main health system for the community in Ladakh region. Not only in Ladakh, entire Himalayan belt from Laon Spiti in Himachal Pradesh, Arunachal Pradesh, and Sikkim, and this Darjeeling Kalimpong area of this entire region. This was the main medical system. Even some neutral person have conducted research, and they found that even 50 to 60% people were relying on this medical system. And it is not easy for government to provide full-fledged health system in the rural area. Even WHO has acknowledged if we want to achieve health for all, then we have to strengthen our traditional medical tradition. So that's why it is so important to strengthen the medical system. We have seen medical systems, we have primary health centers and medical aid centers in rural areas in Ladakh, but that is only during daytime. What happens if something happens in nighttime? They're only their community people. So introduction, Ladakh is the northernmost part of India bordering China and Pakistan, most of us know, but the Union Territory of Ladakh is dominated by tribal communities. 90% of the people are tribal community, and the dominant tribes are Boto, Balti, Jokpa, Changpa, Gara, and few other small tribes are there. And considering its tribal dominance, many people in Ladakh are now demanding to include Ladakh under the 6th schedule of Indian Constitution. Many of you must have heard about this current this agitation is going on. And the native of the region has very rich culture and tradition. The traditional Swarikpa system of medicine is one of the classic example. This is Ladakh, the geographical area, and this is where the entire area is highlighted here in this map. And Swarikpa for public health actually is very important. Swarikpa has been the only healthcare facility for the community until recent times, that is until 1960s, Swarikpa used to be the only healthcare system, and gradually modern medical setups have been done, but they could not replace Swarikpa due to its strong community support. And in our ancient socio-political system, each and every village have been having their own traditional healer. And we call it Rudpa Amchi lineage system. And also in Guru Shishya Parampara, also many used to go for education. Now the institution, training is institutionalized. Earlier time, it used to go through community examination. When the son is ready to take over the position as village Amchi, he has to go for community examination. And after examination by senior practitioner, then they used to offer this title of village Amchi. Now, gradually, government is accepting all these things, and most of the PHCs now, Union Territory of Ladakh has incorporated Swarikpa into main medical system with the Ayush system, but there was difficulty for acceptance of other Ayush system like Ayurveda, Unani, Siddha in Ladakh. That's why the government is emphasizing to have Swarikpa medical system in co-locations. Swarikpa and the journey of Swarikpa from tribal health system, or if you look at Indian medical heritage, we have two types of medical heritage. That is, one is codified classical system of medicine, which is popularly known as Ayush system, where each and everything is documented, and we have sets of rule, and we have proper theory and practice. And another big, which is neglected part, is the folk tradition, folk healing, which is we are talking about now, that it should be strengthened. It may be a community medical system, or maybe family tradition like Dadimake, Nuske type of systems. But these are very important because, as I told you earlier, without strengthening this kind of medical tradition, and we have successfully done it in Ladakh by strengthening the traditional healers, that I will come on later. And this is the thing that how Swarikpa was incorporated under Ayush system. We have been educating for a very long time that it should be recognized as a recognized medical system. And luckily, I remember during 2005-06, then Health Minister Dr. Ambumani Ramdas visited Ladakh. That time we had a detailed discussion, and he was convinced that it should be recognized. We should take Swarikpa into mainstream Swarikpa. It is a full-fledged medical system and constituted later. Then the government shift and Ghulam Nabi Azad Sahab came as a Union Health Minister, and he constituted a committee. And through that committee, I was the member secretary. We have made a full-fledged case study that why Swarikpa should be incorporated as a new Ayush system. So government is, after lot of scrutiny, even it went to Standing Parliamentary Committee for Health, and government decided this should be recognized, and Swarikpa bill was passed in 2010. And luckily, it was unanimous. All documentation was so nicely done. So government, all the member of parliament has unanimously passed the bill. This is the gazette notification. And introduction to Swarikpa. Actually, Swarikpa, even during this deliberation, hardly anybody took the name of Swarikpa in Ayush. Actually, now Ayush is stand for also Swarikpa. A for Ayurveda, Y for Yoga Naturopathy, U for Unani, S for Siddha and Swarikpa both, and H for homeopathy. So it's formally incorporated, but still we have to make this popular in other parts of India. And I'm very thankful to the organizer, particularly Sanjeev Chaudhary Saab, for thinking about Swarikpa, and he at least thought that it should be made familiar with other parts of India, particularly this kind of other August gathering. And this is actually not pertinent to Ladakh only. Swarikpa is prevalent in many other Central Asian countries, particularly Buddhist-dominated areas. This is the medical system. Also, same medical system is practiced in Bhutan, but it is called traditional Bhutanese medicine. It is practiced in Mongolia, they call traditional Mongolian medicine. And in India and many other European regions, it is popularly known as Tibetan medicine. In reality, it is Indian Buddhist tradition of medicine, which was exported to Tibet during 7th, 8th century and incorporated with a lot of information from Tibetan province, particularly according to the ecoclimatic condition and bioresources of Trans-Himalayan region. So this is when it was originated from Buddha, and it was later propagated through Jivaka, Nagarjuna, Bhagavata, Chandranandan. All these are Ayurvedic experts. It was later translated into Bodhi, but it is, as I told, it was modified when it went to Tibet. This is Bhagwan Buddha. Actually, this is 7th century practice, you know, where it is depicted that how Swarikpa is was preached. It was near Bodh Gaya. There used to be one Sudarshan one. Buddha first sermon gave about medicine there. These are the fundamentals actually, like I said, it is originated from India. So it is based on Pachma, Bhuta, Tridosh, Saptadhatu, all these theories. But in philosophical core, we follow more Buddhist practice and Buddhist fundamentals. And compassion is the main thing behind the motivation of practicing medical systems. So this is the fundamental actually theory of body and all these things. I cannot go into detail, so there's very limited time left. So this is concept about body. There is healthy and unhealthy body and how it gets sick, and all these things explanations are in this typical Tibetan Thangka paintings. Actually, this is set of 80 paintings which was drawn in 18th, 17th century, and it is nicely depicted each and everything. Now in modern times we do in diagram. That time they used to explain in the name of trunk, tree, root, then this kind of branches, leaves kind of thing, then they get into much detail. This is about diagnosis. We observe visual observation, feeling, particularly pulse diagnosis is very popular, then questioning, history taking. Then in treatment of patient, we use food and beverages like then behavior, then medicine, then accessory therapies like we have in Ayurveda. Then I'm coming to what we are doing regarding how we are strengthening tribal health through Swarikpa in Ladakh. Actually, Ministry has a separate component called for under TSP. Within that, we have floated a project where we are providing, we have a fixed clinic in 2-3 locations, and we are continuously doing mobile medical camps in far-flung regions, and reorientation training is organized to strengthen the local village healers so that they can take care of their own population in Ladakh. Otherwise, Ladakh is so scattered. This is one typical this thing, you know, like village are small hamlets, and it is very hard to provide public health in each and every nook and corners. Particularly, even there is medical aid center only daytimes. These are some of the activities we are doing. This is Swarikpa Tribal Mobile Health Clinics. This is regularly, we are doing it on regular basis from last 12 years, and it is very popular among tribal communities in Ladakh. This is direct health giving through Swarikpa to the tribal community. And number 2, we are trying to strengthen the local traditional healers. We have almost 300 plus traditional healers who are practicing in this tribal areas. So to achieve health for her, it is very important to strengthen their education system. Plus, we are also maintaining our philosophical core. There is many spiritual aspects you can see on this right part of the thing that this is spiritual practice also associated with Swarikpa. And this is participation in National Health Program. All the traditional healers and all the other things, we are going to traditional healers with each and every government health programs. Any unique features of Swarikpa? Why Swarikpa is special? Because it has a living tradition of more than 2,500 years. Since Buddha, it came to from India, it went to Tibet, and from Tibet it went to its neighboring region, and it is most recently mined in medical tradition. I told you it was mined till 17th century, and there is collaboration of Indian Ayurveda, Chinese medicine, Greco-Persian, and Tibetan folklore, holistic approach of body and mind, nature for complete balanced health, strong socio-cultural background, spiritual link, natural and herbal, skillful use of Himalayan herbs, and we are using the pure Himalayan herbs with efficiency, cost-effective, easily accessible, and we have standard parameters. It is not like just undocumented kind of. I told you there is second stream, which is folk tradition. This is classical parameters for each and everything is available in Swarikpa. This is the strength of Swarikpa. You know, it is why Amchi Swarikpa should be promoted. It is culturally acceptable, minimum side effect solution for chronic disorder, natural, environmental, time-tested, safe, effective. These are the strengths. At the same time, we have potential to go, take it for economic benefits. Like we can do pharmaceuticals from Swarikpa products. We can do nutritional project products, holistic health solution for chronic disease. Medical and ecotourism is coming up, particularly now UT government is thinking about developing there is a lot of hot spring, which is popular in many other European regions. In Ladakh, we have a lot of hot spring. Now government is emphasizing to develop some as a kind of holistic health facility with hot spring therapy. And this is like Swarikpa industry is not small industry. Actually, it is a big industry. The major part is taken by China. You can say the total value is this one almost. It was, I think, 2015 data. There 870 million US dollar business is done by China, and 7.2 is done by India. And in India, actually, most of the business is done by Tibetan community. There is Tibetan government in exile. So that government in exile, particularly Mansikang setup is there, and they have clinics all over India. And this is their business setup, and this is some product, you know. One side, this is some Mansikang product, and other side is Switzerland-based company with the name Padma. They are doing a lot of product there, and it is scientifically developed product, and it is legalized to sell throughout in Europe. And Soarikpa is recognized in Switzerland as Tibetan medicine. And this is because of our effort. Now, Government of India has established a national institute. Earlier, when I started my career, almost during 1997, it was just in rented accommodation, and gradually now with we have raised the issue with Honorable Prime Minister, and now there is a National Institute of Soarikpa is set up, and all the major infrastructure is coming up. So with all government support and community support. So now I'm coming to the conclusion, actually, how important the traditional knowledge is defined by Dr. S. Radhakrishnan. His remarks were, it was centuries of living to make a little history and centuries of history to make a tradition. So let us find a way to link modern science and traditional tribal knowledge for the benefit of universe and mankind. The scientists must make the scientists so simple that it should become a tradition, and traditional knowledge holder must get prepared to revalidate their traditional knowledge to fit into present scientific age. Thank you for your patience.
Thank you, sir, for your insightful presentation. Your expertise on the subject was enlightening. I now request our esteemed chairpersons to put forth their views of the session.
Thank you very much for this wonderful opportunity. For this, I am really thankful to Dr. Chaudhary, Vice Chancellor Madam, Dr. Joshi, Director AIMS and Pro Vice Chancellor, and all the esteemed dignitaries. It gives me immense pleasure and pride to have been presiding over this session. It was really for the how we promote the traditional healing practices into the mainstream, and how we harness the potential of traditional practices and the medicine for the better outcome of the healthcare system. And to our surprise, it was continuation of the first session. I think it was for the gene editing and genome editing, the first presentation. All the three presentations were eye-opening and very important. The presenters, the Sony, who really gave us the wonderful CRISPR idea about the genome editing, how the gene repair is done and how it is useful in various diseases, COVID-19 and sickle and other conditions. And I just would say, since this session is a traditional medicine session, so I want to say that there are some instances in Ayurveda about the Garbhadhan Sanskar and Pusavan Vidhi. And it is always said that the absence of evidence is an evidence of absence. But now we say that there is a gene editing, gene repair, but it's age-old practices if we really understand the mechanistic approach, and that really talks about the gene editing itself. But now we have the technology and the science. If we integrate this traditional wisdom with the science and technology, I'm sure we will bring more wonders, and that will also have the better leads for the future research. So thank you, Dr. Soni. The second presentation, and yes, and Madhuri Kanetkar madam also mentioned about to throw some light on the Prakruti, because in the earlier panel discussion, there was a discussion on Prakruti, what is the constitution, how it really helps in the gene. So it's a epigenetic changes. It is mentioned about how the climate change happens, what are the effects of the environment, climate, lifestyle. So it is a Deshanupatini, Vayanupatini, Kalanupratini Prakruti. So that really helps into the on the epigenetic expression, gene expression of the individual. So climate change really happens, and the traditional people and even that affects to everyone on the globe. So it is a planet and people, so well-being, that also really affects, so that aspects are also important. Now coming to the second presentation of Dr. Jalal Bismillah from Liberia, about, she presented very well about the traditional healing practices, bone setting and various forms of the healing practices, and how really helps in STD from the Liberia, and how this traditional healing has been really helped, and how the government support from the temple and other regulations, latest policy also has been mentioned. So I would like to inform to each and everyone who is in this August auditorium that in India, we are blessed to have the medical pluralism, and there is a separate medical system as a Ayush. Ayush is a traditional medicine indigenous system of India, but it is a conventional, it is a health codified, regulated, very well organized medical system, a traditional system across other parts of the world, like in southern part, South Africa and many other countries, there are healing practices. But here in India, where there is a well-regulated syllabus, curriculum, uh, standardized quality control mechanism, 10,000 manufacturing industries. There are 700,000 practitioners, 700 Ayush institutions. There is a separate ministry. And for the education, uniform regulation, syllabi, curriculum, there are research councils. There is a research, education, patient care, primary, secondary, tertiary care system, hospitals, and well-regulated system as parallel to our conventional medical system. And there is a very well-regulated crosstalk dialogue as we are sitting in the Maharashtra University of Health Science. That itself is a transdisciplinary and the health system. So that's what I wanted to say. And coming to that again, that Ministry of Ayush, as the last presentation was of the Padma Gurmit about the Sovaripa and how the Sovaripa has been evolved and has been entered into the main care of Ayush system. So that he mentioned its importance, and we have witnessed in the Ladakh and all the northeast flora fauna that includes the Sovaripa, and more people use them, more than 90% people they use for as a primary care. And when we say that Ayush, Ayush, so Ayush, so earlier it was Siddha, Ayurveda, Unani, Siddha, homeopathy, but now it is Ayurveda, Unani, homeopathy, yoga, naturopathy, Sovaripa, and S stands for Sovaripa and Siddha as well. So it's an official codified regulated system which is officially included into the Ministry of Ayush, and that's why we have National Institute of Sovaripa. So it's a well-regulated research, it is an education program as well as a patient care, and it has a tradition, long, many years tradition, and it resembles very closely with the Ashtanga Hridaya. So Ayurveda, it's all traditional medicine, and all other are the different forms of Ayurveda, so Varipa, Siddha and all. So it's very closely related to Ashtanga Hridaya. And now coming, just Ministry of Ayush has various programs in the tribal research, because how the Ayurveda has been evolved. So it is based on the traditional practices from India and thousands of years. And there are three-tier system, how the medical system has been evolved. Earlier, there were traditional healers, traditional practices, folklore practices. Based on the observational studies, the various research studies had been done long back, 2000 years back, where Charak, Sushrut and other scientists, they have studied, applied their logic as a scientific parameters, and whatever was the Prakrut became the Sanskrit. Whatever was in the folklore and tradition, that become the codified system as a Ayurveda classics. And that's how this well-regulated Ayush system is a part of the traditional medical system like it is in China, like it is in Korea and Japan. In India, we have the medical pluralism, which is Ministry of Ayush. Just for other foreign nationals, we wanted to tell that. And now then it is become like we have various outcome measures, radiology, CT, hematology, but now everything has been uh, have been shifted as a AI powered tool. Today we talked about gene editing. So after 10 years, these also will become a traditional medicine. That's how this medical system is being evolved. The similar is the Ayurveda Rasa Guna Virviripa. That is the medical system of 2000 years back. And now we are talking about the modern medicine. But then after 50 years, this system also will become a part of a traditional medicine. So we have to understand how it is being evolved scientifically, and that's how we have to honor both the system, and there should be a crosstalk and a dialogue between the two science. And as Madam Mitali also mentioned, a crosstalk, mutual respect, and the referral is to be understand. So whatever is the best, maybe healing practices will become the part of the modern medicine if we have the talk with the Ayurveda experts as well. So with this, I would definitely like to hand over. But I just would like to tell about the ministry's various initiatives about the Ekalavya model. There are Adivasi schools. So ministry has adopted and signed MOU with Ministry of Tribal Affairs. So we have more than 10 lakh Adivasis have been beneficiated through these 20,000 students have been benefited to Ekalavya, madam. We have the sickle cell research cell under Ministry of Ayush through CCRS, 14 states. Already there are sections. We have Kuposhan Mukta Bharat, and we have through the Mission Utkarsh, also we are part of this anemia project, and we have many some formulations like Drakshavalaya and other. Those already have been introduced. And in the recent budget, more focus has been given yesterday, even on the primary care. So I'm sure if AIMS, because I was also part of establishing AIMS for Ayurveda for last 6 years, and this model, which is more focused on creating evidence-based practices to the practice-based evidence. So I'm sure with these new budgetary provisions, with the support of the ministry and the university and such coming together, we can do better than anyone else can. Thank you.
Thank you, ma'am. With the concluding remarks, I would like to say something regarding, first of all, what university is doing. In MUHS, with the dealing with the first session that was regarding the sickle cell, where we are started our Nasikal project in MUHS, and second one, the project of Ayush, that is dealing with the Nandurbar region for the tribal sections, which is again dealing by the BJ Medical College and second one Hadapsar Institute of Ayurveda. Second one, I want to say that regarding the Dr. Jalal ma'am, who has given us a good presentation regarding the tribal healers. Now the 5 types of healing methods which are described by her, that is the herbal healers, second one bone setter, third one was the spiritual or divine treatments, folk faith healers. One more thing I want to add in that, that is the folk dance or music therapy is also one of the kind of treatment which these herbal healers or the tribal healers are doing well. Now there are some gaps between them. That is the language or communication gaps that has to be bridges, because most of the people don't know or understand the language, so they can't take the treatment from them. Second one is that identification of the herbs, which are the jungle medicines, where we have to identify and monograph such type of medicine so that the standardization of that medicine has to be done. Then the methods of applications and all the things which the tribal medicine is known, we say is that Aghori Vidya, that has to be again treated well. Then if we communicate integrated practices with the modern medicine, Ayush, that is Ayurveda, also the Soya Rikpa, togetherly when we'll come together for the evidence-based practices and the data has to be collected. Then integrated practices and research work has to be carried out in between all the pathies, that is interdisciplinary interpathy work. And last one, regarding the Gurmeet doctor, uh, one thing is that the purest form of the medicines which are available in the northern land, so we have to study that medicinal part of the Ladakhi medicinal plants, so that we can also find out which are the medicinal properties in that and what are the properties in the other parts of the regions of the India. So I will conclude that today's session in the traditional tribal healing practices, we have to integrate ourselves and bring this all practices in the today's world, so that the good part of the tribal traditional healing methods can be come up. Thank you.
Thank you. Thank you, chairpersons, for your words of wisdom. Thank you. I now call upon all the speakers for this session to come up the stage for their felicitation. Dr. Jalaha and Dr. Padma Gurmeet, kindly come on stage. And as the policies which our chairpersons were just narrating, there are important policymakers who connect us with the government. And we are indeed honored to have one of the policymakers with us. He is none other than Dr. Parinay Phuke. I call upon Dr. Parinay Phuke sir to please come on stage. Dr. Parinay Phuke is member of Maharashtra Legislative Council and is an important link between us and the government. Whatever problems we tell him, he always comes up with solution and is of great help to medical fraternity. I request Dr. Parinay Phuke to please felicitate our speaker, Dr. Jalaha. May I request Dr. Parinay Phuke to please felicitate Dr. Padma Gurmeet. I also request Dr. Parinay Phuke to please felicitate our chairperson, Professor Dr. Milind Nikumb. And I also request Dr. Parinay Phuke to please felicitate Dr. Tanuja Nisari. Ma'am is former director, All India Institute of Ayurveda, New Delhi. And now I request the organizing secretary of FIST-25, Dr. Sanjeev Chaudhary sir, to please felicitate Dr. Parinay Phuke. I request Executive Director of AIMS to please join him. Thank you one and all. This brings us to the end of day 2. There are 2 important announcements. First is tomorrow we have again a packed schedule starting at 9:30. So I request all of you to be kindly in this auditorium. And after the entire day's schedule, we will have the validatory function at 5:30. And we are indeed privileged and to have the chief guest for tomorrow's validity function, none other than the Chief Minister of Maharashtra, Shri Devendra Fadnavis. So I request you all to be please here. Second important announcement is just after this. Soon we will start for tonight's banquet. So please assemble near the auditorium. All the vehicles will be arranged soon. So thank you very much for being here with us today. Thank you very much.